Hello and a very warm welcome to the 8th Singapore Sarcoma Symposium, Clinical Updates and Best Practices in Sarcoma. Let me start by introducing myself. I'm Valerie Yang. I'm a medical oncologist from the sarcoma team in the National Cancer Centre Singapore. I also run a laboratory at the Institute of Molecular and Cell Biology, A*STAR Singapore. Thank you for joining us from wherever you're connecting from around the world. In fact, we have a total of about 300 registrants for this symposium from all over the world. Singapore, Malaysia, India, Thailand, Myanmar, Hong Kong, the Philippines, even from Australia, the United States, France, Saudi Arabia, and Iraq. So good morning, good afternoon, and good evening to you all, wherever you might be around the world. And it's a real pleasure for you to join us today, and we'd love to hear from you through the symposium, and you can even contact us afterwards. So to kick off our symposium, we are honored to have Professor William Huang join us today. Professor Huang is the medical director of the National Cancer Centre Singapore and chair of the Oncology Academic Clinical Program of Duke NUS Medical School, among the many hats that he wears. It's our pleasure to invite him to say a few words to open the symposium. Professor Huang, please.
Thank you so much, Valerie, and welcome everyone to the Singapore Sarcoma Symposium. Hope you're having a wonderful morning today. And I'm William Huang from the National Cancer Centre of Singapore. I would like to just share my enthusiasm for the meeting today for sarcomas, because sarcomas are three things. They're rare but common, challenging but exciting, highly specialized but multidisciplinary. They're rare but common because they're individually rare, but there's so many different types that together they're actually quite common. They're challenging but exciting because while the field is challenging and sarcomas are difficult to treat, but it's also exciting because of many new developments which the participants will share today, and also many new further developments in future. It is highly specialized, yet multidisciplinary, because there are many people here who need to focus on this rare tumor by highly specializing in it, focusing and developing skills in this area. Just for examples, we have the sarcoma peritoneal rare tumor department with people like Clara May and Johnny. We have medical oncologists like Farid, Jason, Valerie. And yet at the same time, it needs to be multidisciplinary because many large teams need to be involved. Gyne oncologists, surgical oncologists, medical oncologists, radiation oncologists, radiologists, pathologists, and palliative care. People who need to get together, cooperatively work together in order to best benefit the patient. They said that it takes a village to raise a child, but I think it also takes a large multidisciplinary team to effectively manage a patient with sarcoma. With that, once again, I'd like to wish you a wonderful symposium today. It looks like an exciting program, and I hope you enjoy it.
Fantastic. Thank you, Professor Huang. Before we dive into the symposium, we just want to spend a quick moment to thank all of the following: all the members of the organizing committee, including Dr. Muhammad Farid, Dr. Mark Puhindran, Dr. Angela Pang, Dr. Johnny Ong, Dr. Wong Rusin, and also with special thanks to Dr. Richard Quek and Dr. Mark Puhindran, who pioneered the Singapore Sarcoma Symposium, which is now in its 8th year of running. It's our privilege to have Dr. Quek join us later this afternoon as the chairperson of session 2 of today's symposium. And heartfelt thanks, of course, to the hard work by Ms. Goh Wei Lin and Vivian Goh, who made this possible. Not forgetting the institutions we represent in this highly collaborative symposium, namely the National Cancer Centre Singapore, the National University Cancer Institute Singapore, and support from the Singapore Society of Oncology, as well as the kind sponsorship from Medtronic. So just some housekeeping issues. This is a quick message from Medtronic, a disclaimer about the use of any products and therapies to make sure it applies to your local context before use. Your personal data is protected and will not collect any personal data about you except what was provided during your registration. And a quick note about privacy and recording. This will be recorded but will not be circulated unless explicitly approved. So we have a very exciting lineup of sessions today with stellar speakers. Session 1 covers novel therapies in sarcomas. Professor Bob Markey is one of the gurus of sarcoma, and he is our plenary speaker. He will be taking us through Ewing sarcoma and how our understanding of disease has changed over time. Dr. Jason Chan will be sharing recent advances in angiosarcoma. Dr. Farid Mohammed will then be discussing the important topic of how we should go about adopting novel approaches when it comes to rare cancer. And in session 2, chaired by Dr. Richard Quack, we have the privilege of speakers from different institutions in Singapore to share their specialist insights into the management of gynae sarcomas. Professor Jeffrey Low from NUH on surgical management, Dr. Chan Wan Ying from NCC on radiological imaging, Dr. Satya from NCC on pathology, Dr. Chu Bok Ai from Icon Cancer Center on radiation therapy, and Dr. Angela Pang from NUH on systemic treatments in uterine sarcomas. And last but not least, we will end off with an exciting roundtable discussion of a series of real-life sarcoma cases with input from these esteemed members of the Multidisciplinary Tumor Board. So it promises to be lively and educational with audience polling and participation, where we can pick up some practical and valuable learning points in the management of gynae sarcomas. So with that, without further ado, I would like to hand over the time to Dr. Farid Mohammed, who will introduce our plenary speaker. Over to you, Farid.
Hi, good morning, everyone. Thanks for the introduction, Valerie. My name is Farid. I'm from the National Cancer Center, Singapore. And it gives me great pleasure this morning to introduce our plenary speaker, Dr. Robert Mackey. Dr. Mackey is Clinical Director of the Sarcoma and Phase 1 programs and Professor of Medicine at the Hospital of the University of Pennsylvania. I think he's an internationally recognized key opinion leader in the research and treatment of sarcomas who really needs no introduction. He's been the principal investigator of multiple clinical and translational studies in sarcoma, including the pivotal randomized clinical study establishing the efficacy of gemcitabine in combination with docetaxel for sarcomas. Personally, I had the pleasure of working with and learning from him almost a decade ago now, when I spent a year at Mount Sinai Hospital. An experience which I remember with great fondness to this day. One of the things that always struck me about Dr. Mackey, and anybody who works with him, I guess, will feel the same way, is how broad his knowledge is about literally almost any field. As a clinician, he was very knowledgeable in pathology, pharmacology, trial methodology, immunology, even history of medicine. And he brought all these skills and knowledge to bear on how, on managing sarcomas holistically. He was also one to focus firmly on doing clinically meaningful studies and publishing meaningful studies, no matter how big or small. For example, I remember, many short papers he wrote, like 1 to 8 quick risk stratification in GIST, or summarizing drug toxicity from clinical trials, all of which have immediate and practical value to busy clinicians. Above and beyond this, it was his collegiality, humility, and kindness as a mentor and friend that I will always cherish. It truly is a great pleasure and honor to have him here today. And I just, from a very warm and sunny morning in Singapore, I'd like to extend a welcome to him from what I believe will be a very chilly and frozen night in Philadelphia. Dr. Mackey, please.
Farid, thank you very, very much for such a kind introduction. I really appreciate it. And yeah, it was, it's 30 degrees there and minus 12 this morning, Celsius here. So about 12 Fahrenheit. So it's chilly here indeed. Not a lot of snow though. Let me try and pull up the slides here if I can. And just a moment, please. I think this will be it. And hopefully this is visible to everyone. Does that look okay, Farid? To you? Is this visible? Yep, great. We'll just get terrific. All right. Well, you get 3 milliseconds to look at my conflict of interest disclosure. That's it. We're going to focus on the starting point is this paper. I guess you have the old person here to talk about this old paper, diffuse endothelium of bone, James Ewing. I was really curious to look at the literature and find out if there were other cases of this before Ewing described this important case, which we'll discuss in a little bit of detail coming up. And you start digging and go back further and further, you do find some remarkable manuscripts from the 19th century. And I'll talk about a couple of those first. And there are two papers from the 19th century. The first one is published in 1866, and pretty clearly is a Ewing sarcoma. Patient with axillary lymphocytoma, embolic swelling of the lungs, generalized leukemia, then death, 22-year-old woman. So far, always healthy girl, had an axillary mass. The mass grew satellites. She ended up getting admitted for pain control, was given morphine, and basically was observed and died over the course of 5 or 6 months. And the diagram that you see there on the right is the autopsy showing the bulk of disease from what may have been actually a pelvic primary. And this dates all the way back to 1865, long before the day of Ewing himself. And then there's this guy. This is a famous painting by Thomas Eakins, one of the more famous portraitists here in Philadelphia from 1875. Philadelphia, there were something like 25 or 30 medical schools in the 19th century. It's gotten quite a few fewer at this point, but Dr. Gross, who you see pictured here with the scalpel in hand and blood all over his hands as well, operating in the operating theater at Jefferson University, this competing hospital, one of the hospitals in town here. And Eakins is shown sitting in the front row drawing here on the right side of the aisle there. Dr. Gross was the advisor to the U.S. Surgeon General and published texts on military surgery during the U.S. Civil War, 1861 to 1865. And his a great reputation of being an excellent surgeon and teacher, 20th president of the American Medical Association. So they honored him with this painting in 1875. It showed at the 100th anniversary of the U.S. here in 1876. And it was such a gross and disgusting painting for the time that they shoved it in the back of the medical tent. It was not really on common display. But as you probably recognize, if you've been to Amsterdam at all, you've seen the picture of the anatomy lesson of Dr. Tulp from 1632, and it does recount that to be sure. So why do I mention Dr. Gross? Well, Dr. Gross wrote this really nice article on the sarcoma of long bones in 1879, and he was the Mutter lecturer. Dr. Mutter was a professor at Jefferson, and he donated his anatomical model collection, which is now a museum in downtown Philadelphia. So another reason to do some medical tourism here if you get a chance. But Dr. Gross saw enough of these tumors to begin to characterize them, and he indicated how they grew, whether they were actually central to the bone or periosteal, described some of the shapes of the cells, and in some cases described the cell type as well. Codman, who reviewed his paper later on, didn't think there was much clinical meaningfulness to clinical meaning to any of this system of the location of the tumors. And Gross always advocated for amputation, but despite that, nearly everybody died of their cancer. But this surgical material that he wrote up in this report is just remarkable to see, and you instantaneously recognize Ewing sarcoma on the left and osteosarcoma on the right. And it's all the more remarkable because X-rays weren't even discovered until 1895. So we had these gross specimens that had to be hand dissected and then documented in such a lovely way. And the distribution of these cases also fits very well for young people who get these tumors either around the knee, shoulder, and hip. Well, let's get on to James Ewing. He had osteomyelitis himself when he was 14, and he was stuck in bed for 2 years and remained disabled throughout his life. He was always interested in nature and science and won a microscope from a contest where he figured out the most words from the word Constantinople. He won that contest. He eventually went to Amherst in Massachusetts, graduated 1888, went to Physicians and Surgeons, which became Columbia. In 1891, he was an Army surgeon as well. He became the first professor of pathology at Cornell, and then in New York in 1899. And amongst other things, he co-founded the American Cancer Society. He demonstrated the infectious transfer of cancer. He was the first American Association for Cancer Research president and moved to Memorial in 1910 to establish clinical research. And he died of bladder cancer after diagnosing himself from his own specimen. This is a great book that he wrote, 1,000 pages on cancer, written already over 100 years ago. And there's his classification on the right of these tumors, including this endothelioma, angioendothelioma that we got to know as Ewing sarcoma, but some of the other diagnoses that you also recognize. And a big focus for today's meeting, the GYN sarcomas. You're really asking a lot of the right questions. I'm excited to see that being discussed, although I may be falling off to sleep by then. His index patient was a 14-year-old girl who had nasal discharge and bleeding and ocular symptoms. Actually half of bone lesions were syphilitic in the era. And so when she had a positive antibody test, they gave her basically arsenic, which is also compound 606 at the time. That was the 6th compound in the 6th screening test to show if you could have anti-syphilitic activity in a mouse system. Didn't get any better. Also then spontaneously had an ulnar fracture a bit later. That swelling resolved, and when that got worse again, people thought that she had osteosarcoma. She was treated with Coley's toxin at the hospital where both Fareed and I worked, Mount Sinai in New York, but didn't get any better. Then got radium treatment and did get better. You'll see the pictures in the next slide. She did well for another 18 months or so before she presented with what appears to be other bony metastatic disease and died. She also noted in this series 7 other patients with a similar diagnosis and uniformly fatal outcome. Well, here are the pre and post radiation images, the x-rays of this patient. You can see the rapid improvement, and very similar to what we see today with today's therapy from this case from 1920, and the small round cell tumor histology on the right, very characteristic again of this diagnosis. So how do you study rare cancers? We're doing that again now. You phone a friend, or maybe they telegrammed or wrote in longhand and cheeky English, but he contacted or was contacted by actually Ernest Codman. Yes, that same Codman, Codman's triangle. He was a physician who worked on outcomes research before anybody else did back in the early first half of the 20th century. He had these end result cards that helped him do quality analysis, quality improvement sorts of studies. He worked for a while at Mass General, but worked at other hospitals as well. His other colleague was Joseph Bloodgood at Johns Hopkins. He's a gentleman who proved the benefit of rubber gloves in surgery by first showing that there was a certain risk of infection postoperatively. When you didn't use them, then everybody used gloves for a period of time, and he showed that he reduced the risk of infection by 90% or more. And he was notorious apparently for collecting lots of data. People chided him for having all this data on the patients that he had seen and not doing anything with it. Well, they decided to do something with it, and that's where this registry came about. These 3 put together their cases, and then they asked for cases from all over, and they took a look at them themselves, and they indicated that, well, about half of these were actually metastatic carcinoma and other benign processes. And then they published on features of what they should consider osteosarcoma and what was eventually called Ewing sarcoma as well. They also confirmed the poor survival rate regardless of whether they had osteosarcoma or Ewing sarcoma. And they had enough cases so that by about 1940, Ewing asked that they only send the weird ones to look at. So this sort of analysis gives us the understanding of the clinical features of Ewing's that we understand today. The peak age in the teens, 1.5 times more boys than girls who are affected, and the different sites that are found that you don't see nodal metastases, but you do see metastases to lung and bone. It's more common in Caucasians than in other ethnicities, and you see the characteristic translocation, which we'll talk about later on. It was only later that, with understanding of the translocation, that we learned that soft tissue Ewing's is the same tumor, but it's more common in adults than it is in children. Here's another series. This is represented the standard of care even up to about 1950. This came from Mass General, and it's nice to see that. Wouldn't it be nice to have a series published in the New England Journal of 50 patients? A simple description of that. And very similar outcomes. Median survival is only 10 months, and you can see the long-term survival here is also only about 10%. Oh, by the way, he never could put together a survival curve like this because Kaplan-Meier analyses weren't written up until 1957, 58. So this is the first graph that I've ever seen of these data. Dr. Wang and Dr. Schultz worked at Mass General, and in fact, Dr. Schultz handed the baton to Herman Suit, who was famous for working on things like chordoma and establishing some of the radiation treatment plans for Ewing sarcoma himself. very busy clinicians at MGH. And here's a Mayo series from Dr. Dahlen, one of the pathologists there. And again, as of 1960, not much had changed. Of course, Dr. Dahlen, he has a bone tumor book, which is published to this day. So you can see how the impact of these pioneers in Ewing sarcoma and osteosarcoma impacted the field really for all time afterwards. So here's the standard of care in the 1950s and 60s, amputation, or once people recognize that, at least for Ewing sarcoma, that you're going to metastasize anyway, well, don't amputate, just radiate. And that really became the standard of care. And in fact, Herman Suit's regimen is by and large what you see a lot of the time now, 45 gray to the primary tumor and then a 20 gray boost. And also useful, obviously radiation is useful for metastatic deposits. Then systemic therapies kicked in. As you saw in that initial case, Coley's toxins were ineffective overall, and other studies you can dig up in the literature. Methotrexate didn't do very much, and vinblastine and mercaptopurine didn't do very much. But then they began to see some evidence of benefit with single agents listed here. And for example, with the cyclophosphamide, they described a case series, and there seemed to be some quote, suppression of cancer growth for a period of time, and also other alkylating agents like carmustine, BCNU. You can find cases, at least of Ewing sarcoma, who responded to treatment. Of course, medical oncologists and I'm sure our surgical and radiation colleagues roll their eyes about the obsession of oncologists to combine treatments. And of course, obsession is a word the lazy people use to describe the dedicated, but of course also stalkers and hoarders, but still, that's medical oncology for you. So I'm going to shift from metastatic disease to primary disease. We saw that there were some responders there in those initial cases of single agents. And it was already known by the mid-1970s that chemotherapy was effective for rhabdomyosarcoma. So why not use that same combination for Ewing sarcoma? And this is what Norm Jaffe, when he was at Dana-Farber, worked on. And this built on some work that was done at St. Jude's as well. Dr. Hustu, this report from Cancer in 1972 showed that the combination of vincristine and cyclophosphamide showed some evidence of benefit to historical controls. When he started using vincristine, dactonymosin, and cyclophosphamide and comparing those to historical controls, again, not something we normally do now. We do a formal randomized trial, but at least in this case, there seemed to be, in this graph on the right, evidence of better survival in patients who received chemotherapy than those who did not. So this really very quickly became a standard of care and was implemented early in the management of patients. Jerry Rosen, who you may have even seen at some of the sarcoma meetings, haven't seen him for the last year or two, but a regular attendee. This was his combination for Ewing sarcoma, and it was also effective using much the same drugs, but just on a somewhat different schedule. We can see how intensive this was. This was already 8 cycles of therapy to start with, over at least 9 months or longer. And of course, anti-nausea drugs, real ones. We didn't have anything beyond metoclopramide until 1990. So you just can't imagine how difficult this was for patients in the 70s and the 80s with the barf bags at the bedside and treating everybody inpatient. How different things are now. What he did show, Dr. Rosen, was that there was excellent survival for this group of 20 patients. And the other thing that was important that they showed, as shown in this figure here between the left and the right, there's no longer any amputation, there's reconstructive surgery. So with improved techniques such as became available to orthopedic surgeons, this relatively primitive orthotics were able to be used and help salvage limbs, much as was done by Rosenberg and Brennan, showing this at the NCI, that this was equally effective to do this rather than amputating for soft tissue sarcomas in the late 1970s and early 1980s. Completely different world. Other changes happened during the 1970s as well, which revolutionized how we treat patients, which don't really think about. That includes the use of CAT scanning, first available in the 1970s, and of course of MRI, which also became available for the first time in the early to mid 1970s. This MRI is actually a picture of a finger in the actual MRI scanner, the first picture of one taken in 1977. The other massive discovery that's worth mentioning is the actual physical structure of a complex molecule. This was not insulin. This was not a single chain sequence of, let's say, myoglobin or hemoglobin. This was a complex multi-chain protein IgG, which was figured out by Jerry Edelman and Bruce Cunningham, shown there on the bottom right. Dr. Edelman won the Nobel Prize for this. He published a series of about a dozen papers in biochemistry to come up with this triptych digest map of IgG, and with this, they really did revolutionize how we think about and use these molecules. And of course, we use these all the time in pathology, and of course, as therapy for patients, be they naked antibodies or conjugated to chemotherapy toxins. So as of the late 1970s, we could measure tumor better. We could diagnose them more accurately. We could avoid amputations, give radiation, chemotherapy. We began to work together as groups. And we also had the statistical tools to help us figure out which tool was better. And so the modern era of viewing sarcoma treatment had genuinely begun. And so here you have, after that, the next 40 years of research written up as about a dozen studies here. We're not going to go through all of them, but you can see how the improvement in survival came about in just a few slides. So we can review 50 years of research in essence in just a minute or two here, really, which is just remarkable. And one of the early studies that was important in Ewing sarcoma was the comparison of the standard dactinomycin regimen that you just saw to the addition of doxorubicin. And this was the IESS-1 study. Mark Nesbitt led this from the University of Minnesota, as with a little accent there, as they speak funny there. And they looked at the combination of the dactinomycin containing a backbone with doxorubicin, and also used the dactinomycin containing backbone and added radiation to the primary site. And you can see how survival was improved for extremity primaries, but not for pelvic primaries, both with the use of radiation and with the anthracycline addition as well. So that quickly became established as another standard of care. Thereafter, there was a little bit difference in the schedules for each of these regimens, but they pushed the dose intensity of therapy in the second study. And when you increase the dose of cyclophosphamide and of doxorubicin, outcomes were still better, both in terms of recurrence-free survival and overall survival, a study led by Dr. Burgert at the Mayo Clinic. And now we enter more modern times with Holcomb-Greer's study through the precursor to the Children's Oncology Group. This is INT 91, and this compared that backbone, the VACA backbone, to the addition of ifosfamide and etoposide. I'm sure you're all familiar with these data, that this 5-drug regimen was better than the 4-drug regimen, at least for primary disease. Interestingly, it wasn't better for metastatic disease, presumably from the idea that if you had just gotten the VACA regimen, you could later on get ifosfamide and etoposide and still do just as well. So there really maybe not have been synergy between ifosfamide and etoposide and the backbone, VAC being with the doxorubicin, but rather that there was at least additivity of the combination. So again, this quickly became the standard of care. We're now up to a 72% overall survival at 5 years. This led to the compression of all of that chemotherapy from 17 cycles to 11 cycles. In other words, trying to give bigger doses of therapy, a smaller number of cycles, and the outcomes weren't any different in this particular trial. And in fact, there was more toxicity when you increased the dose per cycle with the fewer cycles. So COG decided to do the converse study to compress treatment now to 2 weeks when possible, but using those old doses from Holcomb-Greer's INT 0091. That led to this study, and this was the interval compression study, in which you're looking at 2-week versus 3-week intervals for therapy. This didn't quite work out, both in terms of the p-value, p.056, and so you don't make it in a New England Journal unless you've got a p-value of 0.05 or less. Nonetheless, it's really important data, and again, I think established a good standard of care that's held up in subsequent study. The other key bit of information that I'm not showing here as well is, even though you're assigned to the 2-week schedule, oftentimes on average, patients could only get recycled with their next treatment after about 18 days or so. So the idea, the concept was there, but the execution of it still wasn't possible, even in kids, to get it down to those full that full 2-week cycle. But nonetheless, this now represents the standard of care again for standard risk patients. The most recent study was to try and add another active agent on top of ifosfamide, and that's the addition of topotecan in combination to the VAC-IE backbone. And this did not lead to any evidence of improved survival. But boy, these survival curves sure look a lot different than those curves from the 50s and 60s, don't they? Just like with acute lymphoblastic leukemia. And even though this was a negative study, these are the best outcomes to date of any trial, even for the control group, and I think reflects the better understanding of the disease overall at centers across the country. Literally 300 centers could participate in the study if they wished. The key unifying study from Europe, Europe followed a separate track, and they separated out the high-risk patients, those with pelvic disease, more than 200 milliliters of tumor. Those are sorted out pretty quickly, but for at least the standard care patients, the key unifying study was this one, where they compared the European backbone, the VDA combination, where you put all the drugs together in one combination versus this alternating VAC-IE backbone. I would have thought that giving all the drugs together would have been better, but it turns out that the alternating VAC-IE was the superior regimen, and that really does bring the world together in many ways in terms of the dose and the schedule of the agents that will now serve as a baseline for future studies. Although it's going to get harder and harder to study, except in the highest risk patients, to be sure. So conclusion is that surgery and oftentimes radiation, that's a little bit of a question still, whether it's necessary to give radiation, and this 5-drug combination are the best standard treatment for a primary Ewing sarcoma as of 2021. So in terms of metastatic disease, there are too many studies to cite. Let's just take a look at the best one, especially since that's going to come out in publication in its full form soon. You really don't want your Ewing sarcoma or your other pediatric sarcomas to come back, rhabdomyosarcoma, osteosarcoma. Patients do terribly when you have that diagnosis. So keep this in mind. It's about a 10%, 12%, 6-month event-free survival, no matter what you do for patients. This is a summary of some COG trials that were all in essence negative, and it gives you a good baseline because of how solidly bad the data are. And I just want to mention Martin McCabe's and colleagues' brilliant study, which really has now collected interest worldwide, and I think Singapore is participating in this as well, in which first-line metastatic disease therapy for Ewing sarcoma was not defined. Again, this was on a VDA backbone for most patients, since this was run in Europe initially. But all of the active regimens were tested, or several active regimens at once: gemcitabine docetaxel, the combination of irinotecan and temozolomide, or of cyclophosphamide and temozolomide, and topotecan, Cytopo. And then the blue box is ifosfamide as a single agent at 15 grams per meter squared. Ouch. Super high dose therapy with that single alkylating agent. After 185 patients, they used a Bayesian design to choose and throw away the least active regimen. Bye-bye gemdocetaxel. They then randomized some more patients and did a second analysis about a year later. And with this one, temozolomide irinotecan went by the wayside, interestingly leaving cyclophosphamide topotecan and ifosfamide at 15 grams, and just announced data in abstract form, but not in any publication yet. The announcement at least was made that ifosfamide was the winner, and now it's going to serve as the contestant for future arms for this study to move forward. And here are the outcomes as of the second interim analysis. You can see that the Cytopo and ifosfamide arms are in the darkest bar all the way to the right. Not much difference though between those and irinotecan and temozolomide, for example, but pretty clearly different from gem and docetaxel. So it may come down to toxicity still for the choice of which combination of agents or agent for your patient. I think there'll still be some debate about that. And here's the all the red X marks the outcome for all those negative studies. So pretty clearly we're to the right of that, and that's where we need to go in the future, to be sure, with later line therapy. Next step is to add new arms to this study, and one of those arms that's going to be examined is good old carboplatin and etoposide. It turns out that there are other agents that may have activity that are being added as well that I'll mention in just a moment. And this brings up the new targets of interest in Ewing sarcoma. I've listed some of those here. I don't want to belabor the point too much, but some of the VEGF related multiple receptor tyrosine kinase inhibitors have some activity. You see CDKs listed across the list here. Polo-like kinase 1 inhibitors, PARP inhibitors, which by themselves didn't do a whole lot, but with other agents may have some activity. Pretty clearly, when you combine them with other agents, they're pretty toxic as well. And then on the right side, there's some other agents that where we're appearing to perhaps directly target the transgene protein product. And on the upper right-hand side, HDAC inhibitors are also being examined, at least to some degree. So perhaps the most interesting and most relevant of these right now is cabozantinib. This is, of course, is the oral multikinase inhibitor with the super long half-life. Antoine Italiano, who worked with Christine Antonescu for a while at Memorial before going back to France to work and lead phase 1 as well as sarcoma work in Bordeaux. Helped lead this particular trial and showed a pretty high response rate, not terribly durable, 39% response rate with a median PFS of only 4.4 months, median of 10.2 months. And so because of these data, cabozantinib is being added to the RECUR trial as another arm. I think they're working out the details of that now. The big caveat about this drug is that it's got a half-life of 120 hours if you haven't used it very much. And frankly, I think the PK of this drug needs to be worked out with a brand new phase 1 trial with either weekly or maybe twice a week dosing, because it's just really rough at least the regulatory approved doses of as much as 60 milligrams a day. And then, as you saw from one of those previous diagrams, multiple agents target the cell cycle, the other type of checkpoint, cell cycle checkpoints, not immune checkpoints. It sure looks like a potentially simple process, but of course you start looking at all the cyclins and then their kinases and their inhibitors thereafter. It's a complicated situation, but nonetheless, CDK4 and 6 inhibitors might be interesting, at least a subset of Ewing sarcoma CDK9 inhibitors, and then these 12 and 13 inhibitors. They're oftentimes the CDK12 and 13 inhibitors, not even shown here in this diagram. Those are agents that are so similar to, the targets are so similar to one another, they haven't been able to tease apart the targets, just like CDK4 and 6 have been very difficult to separate activity of novel agents as well. And of course, 10 or 15 years ago, we looked at IGF-1 receptor inhibitors. There were responses seen, but there's never been a good explanation biologically why 10 or 15% of people respond to these agents. There have been mechanistic studies taking a look at cell lines and trying to find out who might respond and who doesn't, and just has not been sorted out adequately. So this remains a question mark. Unfortunately, at least in terms of the further development of IGF-1 receptor inhibitors, the most important study perhaps has been done. The COG did an analysis of chemotherapy plus or minus an IGF-1R inhibitor in metastatic disease, and the IGF-1 receptor inhibitor did not help improve relapse-free survival or overall survival. And so once again, it's gone by the wayside, but yet these very interesting data remain very much open question. Of course, other people are trying to more directly target the transgene product. You need to have EWS fly function running to keep Ewing sarcoma cells alive. And the binding of EWS fly to its target changes expression, and we think of it perhaps more even of shutting off gene expression as opposed to turning it on. It's long been considered an undruggable target, until Jeff Turetsky spent his whole career trying to do just that. He developed this tool compound YK4279, which somehow messes up EWSR1 Fly1 function. Perhaps it's binding to DNA itself, perhaps it's binding to other proteins and the complex that it forms at those GGAA repeats. And this was a very difficult study to perform because this required a continuous infusion of the drug over a week to 2 weeks. And then they started also seeing some preclinical synergy with vincristine, so tried to do a second portion of a phase 1 study involving vincristine as well. It's possible that this sort of agent, since Oedipus fly is involved in RNA transcription, could also be useful in other cancers. However, at least for the Ewing sarcoma data that were discussed at the most recent ASCO, that red dot is also a sign of inactive therapy that I showed you from all those other COG studies. So there wasn't a lot going on here. So it's swing and a miss, but it may be for mechanistic reasons. That's going to be a subject, I think, of some future biological work as well. It's not quite the end of the story. We're getting there. I know I'm running a couple minutes late, but I do want to at least touch base on what's happening in sarcomas besides Ewing sarcoma that are similar. And so to go backwards, we have to go backwards to go forwards again. Until 1956, we thought there were 48 chromosomes in humans, and it was only 1956 where, with proper analysis of cell lines, after actually it was a sabbatical at Memorial, interestingly, for Dr. Cho and Levin, that led them to do further work looking for ploidy and the number of chromosomes in humans. It was not until 1983, of course, when the Ewing sarcoma translocation was discovered and really got us going in terms of the molecular genetics of Ewing sarcoma and a number of other sarcomas, now more than 300 translocations seen across all the sarcomas that we treat, making Ewing sarcoma really rather unique, at least at the time, like CML or Burkitt lymphoma, of actually a solid tumor with a translocation. The translocations partners were cloned in 1990 by Olivier Delattre and his group at Curie. And other variant exons were noted to be fused once these two genes were noted to be fused together. It didn't seem to matter in terms of analyses since that time of which exons are used between EWS and Fly1. Other partners also fused to EWS as well, like ERG, which Paul Sorensen discovered. And then there was more news afoot since they found that EWS was also translocated in other sarcomas like desmoplastic small round cell tumor, as Mark Ladani and William Gerald found at Memorial around the early 1990s. And this, of course, has led to all the wholesale genomics that we understand today, has led to any number of discoveries of new partners for EWSR1 and between cytogenetics and FISH and next generation sequencing. We now have an explosion of these tumors, which leaves us somewhere understanding Ewing sarcoma as part of this larger family of the so-called FET or TET family of sarcomas, those that involve either EWS or FUS or TAF15, all of which are very structurally similar, and many which give rise to many sarcomas, such as those that are shown here in this next slide. Again, not enough time to go into these in any detail, but some of these are vanishingly rare. And only a few cases have been seen, but thanks to next generation sequencing, we've been able to find them, and now we're beginning to study them. So how many are there out there of some of these rare subtypes? Emanuele Palmerini, who works at Rizzoli Institute in Bologna, one of the big bone tumor centers of the world, they analyzed 1,800 of their cases, and they found that only about 3% of them were of this rarer variety. Christina Antonescu, even in the super Uber referral service that she runs, they have found about maybe 6% of their cases of these more undifferentiated small round blue cell tumors. So there's a lot to explore with this group of tumors. So what do we need to do? We still need to determine the best lines of therapy for Ewing sarcoma overall. The RECURSE study really helps us in that direction. We really need cooperative research internationally, and we need all hands on deck to understand these extremely rare subtypes that constitute, they're only 3% as common as Ewing sarcoma. And Emanuela Palmerini and colleagues are starting this so-called Graceful project to serve as a many-year project to understand these diagnoses better. And then you also can go back to your old studies and try and find and reanalyze, resequence those cases. It's with sort of those sorts of data that helps us understand that the SICDUX4 translocation tumors do worse, and that the B-core CCNB3 tumors do better overall. So here we are at the end of the day, just like James Ewing, with all of these new molecular data, we're in many ways at both the end of an era with a high cure rate for standard risk patients, and also the start of an era. What do we do for these highest risk patients who still have a significant risk of relapse? What do we do for these cousins of Ewing sarcomas that don't behave so well? And for those patients who we know are cured, is there any way of decreasing the intensity of therapy and yet still achieving that same high cure rate? So we want to go still from discovery to application to cooperation to achieve the best for our patients. And with that, I will stop, and I want to give a special thank you to the staff at the Penn Libraries who helped me pull some of these ancient manuscripts. It was really a joy to be able to do that, and a great pleasure to be able to share some of that information with you today. So thanks very, very much. I look forward to seeing you in person sooner rather than later.
Thank you very much, Professor Maki. Wow, that was a wonderfully illuminating talk. I think all of us really learned a lot. You really took us through a whole journey through how Ewing sarcoma came to even be discovered, and how our understanding has changed about Ewing's. Yeah, if may I just see if there are any questions that anybody would like to ask? If not, perhaps could I kick off with the first question? Prof, I just think that there are so many different agents that we use in the treatment of Ewing sarcoma, and obviously there's new therapeutic modalities and different drugs that we're testing on the horizon. I was just wondering whether, and this might be a very difficult question to answer, but I was just wondering whether, from your point of view, whether you felt that there might be specific front runners that you think might be, applicable to more patients in Ewing sarcoma. Are there specific sort of mechanisms of action that you think might be useful in adding to the treatment regimen? It seems like a lot of the fusion products in Ewing's and the Ewing's family of tumors, a lot of the fusion partners tend to be sort of transcription factors, or things that bind to RNA, or they might be affecting even the topology of RNA or DNA. Do you think epigenetics is the way to go? Is this a disease of transcription? Is there something that we can further add to the regimen that might further improve outcomes and broadly applicable to as many Ewing's cases as possible?
Yeah, I think there's really something to that, Dr. Yang. It's a really, really good comment. The problem have been our tools, right? If we could be more selective in terms of the genes we turn on and turn off epigenetically, without having that happen or damage or do the same thing in normal cells, we'd have a much better leverage. But with HDAC inhibitors, we haven't gotten very far. You can't get to meaningful concentrations without meaningful toxicity, usually in the liver, oftentimes. Or some kind of heme toxicity as well, or just the general malaise that people have. We need those enzymes in the normal cells as well, I think is what that's telling us. But for the other, like the BRD, the true readers and writers of histone, acetylases and deacetylases and so forth, pretty clearly, this Ewing sarcoma translocation product is modifying that, turning off a lot of genes, turning on a select number of genes. So there really has to be a target there. Is that going to be most easily achieved by getting the translocation product off of DNA and or RNA, or maybe there will be something that it's interacting with that we can more easily target. And that's really hard to do because you'll need crystallography information and things like that. Maybe it's that sort of research, the hardcore crystallography, especially given all the new tools that we have to analyze protein complexes using not even fully crystallized structures, but just using electron microscopy and looking at thousands of molecules where we achieve that sort of outcome. Another completely different angle on treatment for Ewing sarcoma that hasn't been explored at all is metabolism. They're rapidly growing cells, and maybe this is where the CDK4 and 6 inhibitors could have most easy applicability. Just throwing something in the wrench to get the tumor cells to stop growing. Will they undergo apoptosis themselves? A lot of these tumors are p53 wild type, so they have intact ability to commit cell suicide. So if there's some way of tripping up the tumor, either be through the cell cycle CDK inhibitors, which have been shown to be really interesting in vitro, that seems to be pretty low-hanging fruit. But we'll see how toxic those drugs are. At least the CDK4/6 inhibitors are available and should be combinable with some of the other drugs we use. Can we combine it with irinotecan or temozolomide or trabectedin to achieve benefit? That really hasn't been examined. So just a few thoughts at least, but a great comment.
Thanks very much, Prof. Maki. That was an illuminating answer as well. I think Farid has his arm up. Go ahead, Farid.
Yeah, thanks. Great talk as usual, Dr. Maki. I wanted to ask you a bit about primary metastatic disease. Because as you mentioned, Greider's study showed that VAC is no worse than VAC-IE for primary metastatic disease. And I think we've talked about this before, but I just want to get your thoughts again. Now that we have data that shows that somehow, the Goldie-Coleman hypothesis seems to be vindicated, right, by the European study for whatever reason. I mean, although we don't really, we don't really understand that. But how do you approach primary metastatic disease? Do you give the same, just a simple Greider regimen, or do you say, well, based on that data, there's no real need to alternate? And then just to complete it, I mean, I want to hear your thoughts about transplant, in primary metastatic Ewing sarcoma.
I left that out here. I left that out for a reason.
Yeah. I mean, there's a transatlantic divide, I think, right, with regards to that as well, and also pediatric adult sort of, Just
we don't see the same patients, right? Yeah, absolutely. So primary metastatic disease really depends on where the Mets are. If you have purely lung Mets, I think there's still a possibility for cure, and maybe those are the people after you give the same combination of 5 drugs, you might consider lung radiation. It's hard to imagine, though, that giving 13 to 15 gray to the lungs is going to wipe out those last few sarcoma cells. So I'm still a little bit nervous about that, but I think it's still certainly on the table. If someone has bone Mets, we don't think they're curable, and I'll typically just give them the VAC combination, try and run that for as long as we can, and then switch to ifosfetopicide. The Greer study, I think, showed us nicely that there's not synergy between the two, and you could do it either way. It's fine. It's not wrong. But to me, it's a little bit cleaner just to be able to give one treatment over and over again, and then go A, B, C that way rather than A, B, A, B, A, B. In terms of transplant, high dose therapy. If there is a benefit, I think the data are for pediatric patients, younger patients who are benefiting, and a higher volume disease, I think. So those are the ones where you might begin to think about that at least, but I don't think there's been any survival advantage that's been seen overall, at least, and at most it's been subset analyses, which I'm not so sure that's a legitimate way to look at things. But as we find more and more clinical factors, keep winnowing down. Fine, just help us find the exact subtype histologically, or tumor volume or pattern of metastases, where you would qualify for that therapy, and I think people will take that to heart. So it's hard because it takes a long time to find those patients, but keep at it. And I think it's still a research type of treatment to give high dose therapy and stem cells back. Maybe we can clean up the marrow better, getting rid of some of the Ewing cells, since we're doing auto transplants for these things. But it's, I think, still a research proposition for people right now.
Thanks, Dr. Maki. We've got a few questions in our question and answer box. Maybe if we could answer some of them.
Yeah.
Someone was asking, is there still a role for total lung irradiation if we do not usually run the Euro-Ewing protocol?
I think the place to think about whole lung radiation is still kind of a classical one. You have lung mets and you have a complete response to therapy. You really are, or maybe a millimeter or less on your scans. Maybe there's half a chance you can make an argument for radiation, but short of that, is that any better than, I don't know, giving another 3 rounds of chemotherapy? Nobody really knows. But that's the population where we'll at least have that discussion. I leave that to our radiation oncologists, and they're still, it's like, yeah, we don't really know either. So, but if there's a population in which it's been shown to benefit from that old IESS study, that's the one.
Thanks, Professor
then-
Markey.
Yeah, and then there's a comment here on what's the cause of these tumors.
Yes.
And is there a statistical study on countries with the highest number of malignant tumors? Well, it's interesting that that does happen more in a Caucasian population than others, and also in young men rather than young women. And that gives us at least some hints, but there's been no smoking gun. There's a very weak linkage between the development of Ewing sarcoma also and skeletal birth defects, things like cleft palate as well. So is there something very deep and profound about some developmental gene, Hox genes, or some of these patterning genes that would be very difficult to pick up, but you might be able to find in a single nucleotide polymorphism or something like that. There's interesting data why these tumors form at all as well. There seems to be differences in populations of the ability to repair certain types of DNA damage, and it doesn't come out as I'm trying to think of the name of the complex, the cohesin complex, and it seems like alterations or maybe SNPs in that may help allow for the production of some of these translocations, which are reciprocal. We oftentimes don't find the reciprocal product, but there are probably more than just a simple 2 chromosomes breaking apart and coming together that we see in that kind of a pattern. It's actually, in at least some cases, more this kind of chromothripsis concept that happens through alterations in the cohesin complex. And I'll have to dig up the papers on those. I can share those after the meeting at some point, which are just really fascinating as a potential risk factor that you can now point at that might explain who gets translocation cancers in general.
Thanks, Prof. Markey. I think Dr. Mark Puhindran has a question as well. And Mark is a surgeon at NUH. Will the day come when surgery is no longer necessary?
There's no cure without good hard steel, right? So yeah, it's possible. And in fact, when we're giving chemotherapy before surgery, you'll find some patients who do have a really nice response. And there are patients where you don't want to operate. If you have a tumor that's crossing the sacroiliac joint, that's a brutal operation to put someone through. And at least for Ewing sarcoma, I think the answer is a bit easier. Those are patients who will say, okay, well, maybe we'll think about definitive radiation for those patients, since we can do pretty well, at least. It's not as good as doing surgery. I think it's still pretty clear that the combination of surgery plus radiation is better than either one alone. So I think it's still a strong standard of care. There may be the occasional person where you've had such a good response that you can go back to the old 1920 regimen, you radiation only for primary treatment, because a lot of patients did have good local control in that situation. But I hesitate when we have such good outcomes from standard therapy at this point. But you can certainly make an argument that at least some patients can do well without surgery. We've certainly had athletes, for example, where they refuse to have an operation, and okay, fine, put a rod in there and radiate the damn thing. They've done that, and there certainly are situations where they've done well, but I think you do compromise at least some patients by doing that. So I would still rather see surgery and then at least, and the radiation question, I think is a more and more difficult question the younger you are. It's a little bit easier for osteosarcoma since the tumors are better defined, but for Ewing sarcoma, they're more diffuse, right? They don't obey tissue planes. And to me, that's why I think radiation is still also part of the standard of care for these tumors.
Thanks, Professor Maki. If I just may make a quick comment, it seems like, there is a population of patients who will do well, and perhaps will require such intensive treatment and they see cure. And then there's also another population where, regardless of whether they're metastatic or not upfront, some of them do well, some of them don't. And clearly in patients who see cure, we have then later on the long-term complications. Are there any efforts to sort of distinguish between these different biologies of tumors? Are there some who require less treatment, some who should require more treatments? And in those who do require more treatment, is more treatment really going to be helpful?
It's such a great question. I mean, all these tumors have the same darn translocation, right? What's so different about them? And I think it may be from some tumors having more than just the canonical translocation. Maybe there are other translocations going on. Why do older patients do worse than young patients? We don't know that either. Is it the cumulative mutation that we have over our lifetimes? How does that impact how we might respond to therapy? So, given the homogeneity even within a tumor, well, every cell in the tumor there has the same translocation, but it turns out that there's still heterogeneity. Some of the cells express more of the transgene, some express less, some are more differentiated, some are less differentiated. What impacts that? That gets to your epigenetics question once again, and to tease that out is a super difficult proposition because you have to be able to assay tumors over time and then be able to do those sorts of epigenetic analysis on a cell-by-cell level. That's a busy lab's work. Many postdoc years will be spent on that question. There's that great review from New England Journal from Stamenkovich and colleagues that's worth looking at. That speaks to some of that. Just in the past, they're also talking about, that was a nice article to announce the 100th anniversary of Ewing sarcoma as well. It's a good article to take a look at in that regard.
Thanks, Professor Maki. And I know we're working you very hard and we're running kind
Not
of
at all.
close towards the end of time, but there's a question in the chat box. Maybe we'll take this as a last question if everyone is okay. Rahul Nagadia says, thanks for the excellent talk. What are your thoughts on management of patients with locally recurrent maxillary Ewings?
Yeah, can some of those patients be cured with proton radiation? I mean, that's what we would hope. But yeah, these local control problems of the head and neck primaries, be they Ewing sarcoma, the skull base choroidomas, the maxillary or mandibular osteosarcomas, when those come back, those are just horrible, right? I mean, we just don't have anything adequate, frankly. And we need better drugs to help our excellent radiation oncologists and surgeons who do such a good job with that anatomic site. It'd be nice to be able to pitch in more from the medical side, but all I can say, it's such difficult cases. Or the rhabdomyosarcoma, same thing, right? The ones that affect the orbit or the sinuses and recur local regionally. All of these are incredibly challenging patients and in need of better treatment from all of us. And just seeing the slide run through on some of the new techniques being used in radiation therapy also gives me hope that things beyond systemic therapy are more rapidly improving too. So maybe as a joint teams, we're going to be able to make progress.
Yeah. Thank you, Dr. Maki. If you don't mind, we had a few minutes actually before we get to the next talk, and there's just another question that's come up on the chat box.
That's great.
From Murtada Abdul Redha. Is there an effective way to protect people from these diseases?
Yeah, I don't think there is, unfortunately, unless we can figure out what's happening with that cohesin complex. We talk about cancer prevention, certainly do that on the adult oncology side. What can we do to help people live longer through preventative means? And there aren't a lot of things that are out there, right? We've had failed studies in prostate cancer. If there's anything that might be helpful, it's maybe revolving around the axis of colorectal cancer, and low vitamin D being associated with higher risk, and maybe vitamin D supplementation there being useful. Potentially vitamin E and its congeners for head and neck cancers, but nothing of the sort for these translocation sarcomas. I think I can't imagine anything for rhabdo or ALL. That's the sort of thing that you're trying to prevent these translocations from happening. I think it's the flaw that we have of being human, or being malleable. You'll find incredible organisms that have survived through evolution for 500 million years that can tolerate 20 gray, 50 gray of radiation, and they still proliferate. But they also have DNA, which is incredibly unchangeable. They don't mutate. So with the ability to adapt to our environment comes a cost, and I think cancer is that cost. So long and short of it is, I think oncologists of all stripes will continue to have a job in the future, even if we got everybody to stop smoking and eat a healthier diet.
Okay. Yeah. Thank you very much, Professor Maki, for your insights. I think those are.
I think the only preventative, recommendation I have is don't eat the American diet.
Ah. Gosh. Okay. I'll take note. Okay, fantastic. And I don't think there are any more questions. Farid, are you all right? Anything else you wanted to add, or?
No, I think no. Thanks a lot. Are you catching the train back to New York tonight?
I am, yes. So I'll tune in on my phone
gosh.
for the coming sessions.
Gosh, good luck with that. Yeah, thanks a lot. Really appreciate you being here today. We have to catch up when we get to physically together at some point.
Absolutely, and hopefully it's ASCO, ESMO, or something in between. With everyone. So it's such great pleasure to see everybody, at least virtually.
That would be lovely. I should say that, probably not just me, but, my fellow colleagues and those of us who are trained together, we're also starstruck to actually see you speak, Prof. Maki, because, we've been following all your papers over the years. So yeah, thank you very much for your time. It'd be lovely to catch up with you at some point, hopefully in person. Yeah.
I'm honored for the chance to speak with you all today. Thanks very, very much, Valerie.
Thank you very much. Okay, so
have a safe trip to Manhattan.
Thanks a lot. Look forward to seeing the rest of the meeting. I'm excited to see the next two yours as well, to be sure.
Okay, sure. Okay, take care.
Bye.
Okay, so I'm gonna share my screen and we're gonna introduce the next speaker. Hope everyone can see my screen. Yeah, so our next speaker is Assistant Professor Jason Chan, who is a wonderful colleague and friend. He is a consultant medical oncologist at the National Cancer Center Singapore and clinical assistant professor at the Duke NUS Medical School. He has special clinical interest in lymphomas and rare cancers, including sarcomas and melanomas. And congratulations, Jason. He is the PI of the Starlight Initiative for Rare Cancer Research, the theme PI of the Singapore Lymphoma Translational Study, Symphony in short. And today it will be really our pleasure and honor to listen to his talk entitled Recent Advances in Angiosarcoma. Is there a role for immunotherapy? Thank you, Jason, and over to you.
Yeah, thanks, Valerie, for the very kind introduction. Let me share my screen. All right, I hope everyone can see the screen clearly. Right, so thanks again, Val, for the kind introduction, and the organizers for inviting me to share this talk. And it is a great pleasure today to be sharing on angiosarcomas, and definitely great pleasure to be speaking after Prof. Maki. I think today, I think the audience is really diverse today. We have clinicians, I believe we have patients as well, and many of our nurses, allied health professionals, and even some researchers. So hopefully there's something to take home for everyone. There's going to be lots of sharing on some of our local efforts to describe angiosarcoma both at the clinical level and molecular genetic level. and I will try my best to break down some of those figures, especially basic science ones, so that it is simple to understand for everybody. So without further ado, we move on. These are my disclosures. So to begin this talk, I think we can all get back to basics first. So sarcomas are really a diverse group of mesenchymal malignancies, tumors, and they are certainly rare and constitute just 1% of all human cancers. But although rare, sarcomas are important, right? So they tend to occur in young people and account for a big share of mortality and morbidity in young adults. So sarcomas can arise in any part of the human body and may be classified according to where they come from, so the tissue of origin. So for example, angiosarcomas belong to the subgroup of vascular tumors, as highlighted here in red. And at the molecular level, sarcomas may also be kind of like classified into whether they carry distinctive genetic alterations. For example, like earlier we heard about Ewing sarcoma, whereby they are defined by a very fixed molecular translocation. And these are sometimes termed as simple sarcomas. On the other hand, there are already over 100 different subtypes of sarcomas. And over the years, some of the commoner ones have been characterized at the genomic level. And several years ago, the Cancer Genome Atlas Research Network has published some of these findings on some of the commonest subtypes of soft tissue sarcomas, and described how some of these molecular subtypes may actually impact on clinical outcomes. So moving on to angiosarcomas. So angiosarcomas are really the 1% of that 1%, and they tend to occur on the skin, and they are the fourth most common skin sarcoma after Kaposi sarcoma, DFSP, leiomyosarcoma. And the cell of origin, where they come from, is believed to be the endothelial cell, which undergoes a series of molecular changes and malignant transformation into angiosarcomas. And but although very rare, there have been several risk factors that have been identified over the years, including exposure to radiation, chronic lymph edema, be it from after surgery, as in after breast cancer mastectomy, or congenital syndromes like Muir syndrome, exposure to one of several toxins, and also sometimes familial syndromes can also give rise to angiosarcomas. So interestingly, we and others in the Asian region, we have shown previously that at the geographical level, interestingly, angiosarcomas appear to be around 7 times more common amongst Asians. And most of the cases we see tend to also occur on the head and neck region, compared to the West, whereby they tend to be more of post-radiation angiosarcomas on the breast. And most of the time, these head and neck angiosarcomas do not carry any clear risk factors, and we do not really know why they happen more frequently in Asians. But regardless, I think the prognosis of angiosarcomas are very poor, east or west, and patients do not usually survive beyond the year, especially with metastatic disease. In terms of treatment, for localized angiosarcoma, the mainstay of cure remains surgery, right? So no cure without cold steel, and surgery with wide negative margins remains the mainstay of cure. But however, it is often very challenging to achieve negative margins due to anatomical reasons and the very infiltrative nature of the disease. And post-surgery, adjuvant radiation therapy may provide some improvement in local control and maybe even survival. So for advanced metastatic angiosarcomas, these are usually treated with cytotoxic chemotherapy and/or anti-angiogenic agents like pazopanib, for example, although there is a really limited efficacy. And this is our own local data from the National Cancer Center. You can see that the typical agents we use include mainly doxorubicin and paclitaxel. And the typical patient with head and neck angiosarcoma would receive the weekly paclitaxel or Taxol protocol with sometimes high expected response rates of up to 70%. Although we do need to be careful of this number, as you can see on this swimmer plot, that the duration of control for most patients usually are very short-lived. So even in patients who do get palliative chemotherapy, regardless of whether they achieve some response or non-response, outcomes usually still remain very poor. And certainly, we do need to look for new agents and new treatment strategies to try to improve these outcomes. And from our own studies, the poor responses to chemotherapy are likely due to one of several factors, including tumor intrinsic factors. So in these angiosarcomas, we have looked at them at the histopathological level. And what we previously identified was a population of rare Bisar giant cells, which actually confer chemo resistance in vitro. And also they are correlated with non-response to chemotherapy. So this perhaps represents a really resistant and aggressive tumor component in angiosarcomas that we have found to be present in close to about 40% of the cases that we've examined. And additionally, it is also interesting to note that the systemic immune response and the tumor immune microenvironment may also affect chemotherapy response. So we previously have shown that in soft tissue sarcomas in general, and others as well throughout the world, that the peripheral blood neutrophil to lymphocyte ratio actually affects tumor aggressiveness, biology, and outcomes. And when we looked at the tumor neutrophil to lymphocyte ratio in the tumor, we actually can see that they are associated with high signals, for example, in angiogenesis or blood vessel development, certain immune signaling in the cytokines and chemokines, and matrix remodeling and metastases, and also correlation with high levels of myeloid cells in the tumor. And all these signals actually confer or are correlated with non-response to chemotherapy. So there's really a complex interplay between what happens in the tumor, the microenvironment, and the host, and many factors that can explain why patients do not respond to the same treatment. So for rare cancer like angiosarcoma, there's really no question that research is important and really absolutely necessary in order for patient outcomes to be improved. And so last year on Christmas Day, I did a quick search on PubMed, and it is rather heartening to see that over the years, there's been increasing studies on PubMed on angiosarcomas. And over a decade ago, already actionable alterations in angiogenesis-related genes have been identified in angiosarcomas. This study led no other than Dr. Mackie himself. And following that, there have been many clinical trials on anti-angiogenic tyrosine kinase inhibitors, and pushing the efficacy limits of systemic chemotherapy. And so fast forward to 2022, what new data do we have, and what is our strategy moving forwards? So next generation sequencing, or the really deep molecular characterization of tumors in general, have contributed to an improved understanding of the molecular landscape of angiosarcomas. And I'll just like to highlight this angiosarcoma project published in Nature Medicine a couple of years ago. This was a patient-driven research initiative led by Corey Painter from the Broad Institute. And this is really a remarkable effort by Corey and colleagues, who published genomic and clinical data collected directly from patients throughout the United States. And in their when they first presented their poster presentation at the CTOS meeting several years ago, it was really very heartening to see that they could actually register recruit 300 patients in just 18 months. And this is some of their data. So they actually performed whole exome sequencing to look at all the different important genes in the genome. And what they found was really a high levels of tumor mutation burden, not in all the angiosarcomas, but more so in the angiosarcomas that arise from the head and neck, face and scalp region, as you can see over here. And in the subgroup of breast angiosarcomas, they described many of them carry non-canonical PIK3CA mutations that may be targeted, right, with specific inhibitors. And at around the same time, our group has also completed our studies on the whole genomic landscape of angiosarcomas in Asians. And here we identified that about half of the head and neck cases that we commonly see in our population actually harbored very high mutation rates, high numbers of mutations. And these mutations were really due to exposure to ultraviolet radiation. And we did this by looking at what we call the mutation signatures. And when we see tumors carrying this signature 7, as seen over here, these are strongly correlated with prior exposure to ultraviolet damage, resulting in high levels of mutations. And we further confirmed the presence of UV damage by looking for other surrogate markers. So we looked at patterns of the mutation, so whether they change from a C to T, these are alphabets at the DNA level, or CC to TT. And also we used certain antibodies to directly stain for the markers of ultraviolet damage. These are known as CPD, or cyclobutane pyrimidine dimers. So if these tumor cells stain positive for CPD, they would have basically active evidence of active ultraviolet damage. And all in all, we identified that 50% of the head and neck angiosarcomas in the local context are positive for UV signatures. And in some of these patients, they may be even associated with improved survival outcomes. So, so with that, naturally, it is widely believed across many tumor types that the presence of ultraviolet signatures and high levels of mutations can predict response to immune checkpoint inhibition. And over the years, there have been many studies already on angiosarcomas and soft tissue sarcomas in general that have reported cases of exceptional responders to immunotherapy, specifically this group of drugs that target immune checkpoint, the tumor immune checkpoint. And you can see over here that the patients with very advanced, locally advanced angiosarcomas on the head and neck, when they carry these UV signatures and high tumor mutation burden, they can have a remarkable response to this checkpoint immunotherapy over time, as seen in this case report published just a couple of years ago. And most recently, a multi-center phase 2 trial, this is from the SWOG group, published their findings on the use of ipilimumab and nivolumab in metastatic or unresectable angiosarcomas. And this has just been published by Wagner and colleagues last year. The primary endpoint of this study was the objective response rate. And it is a small study, as you can see. But out of these 16 patients studied, about a quarter of them actually had some response to immunotherapy, with several durable responses observed in this subgroup. And if you zoom closely at the head and neck cases, which are just 5 of them, 3 out of the 5 patients actually responded to this combination immunotherapy. So to cut to the chase, today's talk is really about whether we should consider immune checkpoint inhibition as a part of our treatment for angiosarcomas. And with all this data, certainly at some point in time, we should consider immunotherapy as part of the treatment trajectory for our patients. All right, and so the bigger question is, out of these 16 patients that were studied, only a quarter of them responded. So certainly, immunotherapy is expensive and is not without toxicity. And how do we select patients for immunotherapy? And which patients benefit and which patients don't. And at this point in time, I think there are already several clues that have emerged in the literature. So our own study done a couple of years ago picked up ultraviolet signatures. And but certainly we saw in our own local data that half of the patients head and neck angiosarcomas carry UV signatures, but yet we wouldn't expect a 50% response rate. So certainly these signatures cannot be the only explanation for response. And a closer look at the transcriptomic landscape or the genes that are expressed in angiosarcomas reveals that these angiosarcomas are driven by mainly two sets of signals. So one group of signals over here, such as E2F, G2M. So these are really signals that promote cell division. So if the cells have high levels of these signals, it will suggest that they are highly proliferative, and these are common signals seen across cancers in general. But importantly, angiosarcomas seem to carry another different set of signals. So these are the interferon gamma alpha response, inflammatory response. So really suggesting that angiosarcomas, or at least a portion of them, would be considered an immunogenic tumor, and perhaps they do have a significant immune component in these tumors. And when we looked more specifically at individual tumors, at a glance, we can see that tumors, as highlighted over here, this panel of tumors, in general, they are more immune infiltrated compared to their matched normal component. So the area of skin or normal liver or any part of the normal body that doesn't have the angiosarcoma would carry much lower levels of immune infiltration if they do not have angiosarcoma inside them. But this is not, again, always the case. If you look at individual tumors and individual immune subsets more carefully, we start to notice differences across the tumors. And we can see that some of these tumors, for example, highlighted over here, this case of AS07, we actually notice that the tumor itself on the whole carry much less immune cells compared to the normal component. So these tumors are typically referred to as an immune cold tumor. And perhaps these tumors may not respond that well to immunotherapy. So because of that, this preliminary data, we started to want to understand more about the immune landscape of angiosarcoma rather than just to look at the genes. And from a pan-cancer perspective, so across different cancer types, we now know that there are at least two important factors that predict whether patients respond or not to immunotherapy. So one is the tumor mutation burden, so how many mutations there are in the tumor. And the other is whether the tumor expresses what is known as a T-cell inflamed gene expression profile. So basically this gene expression profile would kind of be a surrogate for whether there is a pre-existing but kind of inactivated or exhausted immune profile within the tumor. So if patients have both of these factors, high TMB, high GEP, they may be the ones that have the best response or best chance of response to immunotherapy. So we then we wanted to look at this in the angiosarcomas, and what we did was from the RNA-seq data, we then moved on to look at more specific subset of genes. So this is an 18-gene signature done on the NanoString platform to look at whether these tumors carry pre-existing but suppressed immune response within the tumor. And if the tumors have got a high tumor inflammation signature, it basically implies that it is an immune hot tumor and there are lots of immune cells infiltrated within the tumor. And previously in, again, a pan-cancer study that excluded sarcomas, this kind of profile may actually predict clinical response to immunotherapy. So in angiosarcomas, so this data published a couple of years ago already. We actually did this expression profile in about 30 cases. And you can see that what we identified was really 3 distinct subsets of angiosarcomas. And we identified cluster 1 and cluster 2. So these 2 clusters of angiosarcomas were actually lacking immune-related signals and perhaps do not harbor that much immune cells, while cluster 3 was really the subgroup of angiosarcomas that were enriched for immune cells. And these genomic subgroups were actually also correlated with the clinical features. So we can see that subgroup 1, cluster 1 and cluster 3, these were kind of like carrying most of the head and neck angiosarcomas, while cluster 2 was enriched for the secondary angiosarcomas with previous exposure to radiation or carrying other risk factors. And across all the cases, the tumor inflammation signature scores in angiosarcomas were generally high, ranging from 5 to 10 out of 10, and was highest in the cluster 3 tumors compared to 2 and 1. So in generally speaking, angiosarcomas are pretty immune hot, and they are really hotter subgroups within angiosarcomas itself. And I won't delve too much into this, but you can see that when we broke down the individual immune cell types, you can see that in cluster 3, most of the immune cells were actually enriched in this cluster, and more so when we look at the subgroup with UV damage previously. So we confirm this by direct visualization of the various immune cell types using multiplex immunofluorescence. So you can see that immune hot tumors were really immune hot under the microscope. And in general, there was a very good correlation between the nanostring profiling and what we actually visualize under the microscope. And this really gives rise to the hypothesis that perhaps tumors with both a high tumor mutation burden from UV mutagenesis, and if they are immune hot, these patients may actually have the highest chance of response to immune checkpoint blockade. And as a preview of the potential clinical implications of this subgroup, so just a few months ago at the CTOS meeting, the MSK group reported their experience on immune checkpoint blockade in this series of angiosarcoma patients. And you can see at a glance that about a third of the patients derived clinical benefit. This was defined by the group as progression-free survival of more than 16 weeks. And they did a small subgroup analysis of patients with transcriptomic data, so gene expression data. And there appeared to be an enrichment or upregulation of this interferon, gamma, UV response, and other pathways in the group of patients that responded to immunotherapy. So the situation actually gets more complex as we look beyond genomics, gene expression, immune profiling, and we start to explore what we call the metagenome of tumors, and we look at what is the cause and causality of these angiosarcomas. And if you remember, in our earlier slide, we mentioned that in Asia, most angiosarcomas occur in the head and neck region, and most cases do not have a known secondary cause, right? There's no known trigger. And while half of these cases do not have any ultraviolet signatures, their underlying cause has remained unknown to date. And we have for a long time suspected that that may be a potential cancer-causing virus or bacteria or fungus or pathogen that may lead to this additional risk in the Asian population. And just a quick recap that from the WHO, there are 7 known human viruses that that is known to cause cancer, and these have been described and discovered over a span of half a century or so. And in angiosarcomas, what has been interesting is that this is a group of tumors that have been associated with defect in the immune system, and if we compare it, to other similar tumor types with known association with viruses, we kind of for a long time have hypothesized that there could be a virus as well, leading to the development of angiosarcoma. So this challenging work really started on the drawing board almost 10 years ago. And what we did was to really utilize all the available clinical genomic information that we have, followed by a series of validation experiments. And what we did was to basically use the whole genomic data of angiosarcomas. And when we do whole genome sequencing, we get not only the human genome, but also genome from other species, can be from animal, viruses, bacteria, that is kind of like contaminated or contained within the tumor. And what we did was we removed the human component and we matched the non-human component to a known virus database. And most interestingly, the reads actually mapped very closely to this human herpes virus 7 genome. And this particular virus is really a orphan virus, but has curiously been associated with a benign skin condition as well, known as pityriasis rosea, that commonly occurs in young adults. So with this, we first validated our findings using independent methods. So this is PCR and IHC demonstrating the presence of the virus within the tumor. And we also found that the virus tends to be concentrated or found specifically within the tumor component and not the adjacent skin or the corresponding normal lymph node. And this was important as it suggested some kind of a tumor specificity. And all in all, we actually found that this virus was positive in about 2/3 of the cases examined. And these were all angiosarcomas from Asians. And when we looked at the data in more detail, we found that the viral positive subgroup were actually the ones responsible or enriched for the immune response, as we have seen earlier. So, and really, this is the group that harbored a high level of immune infiltration and immune signals. And importantly, we observed that the viral positive subgroup is really very distinct from the group defined by the ultraviolet damage. And the viral positive group had high levels of tumor inflammation signature scores and were really enriched in the cluster 3 angiosarcomas that we saw earlier. And when we integrated all these various pieces together, then we started to see, the big picture that perhaps there are really many different subclusters, subtypes of angiosarcomas, and perhaps, the patients that may have the highest chance of response to immunotherapy may be those with high UV signatures, viral positive, high tumor inflammation scores, and so forth. So taken together, what we have shown is that the presence of unique subclusters of angiosarcomas may actually impact on treatment, and certainly could be important considerations for therapy selection and patient prognostication in future. So, right, so is there a role for immunotherapy? So I think yes, at least beyond first-line therapy or in patients who decline or are unsuitable for chemotherapy, it could certainly be considered. And we are currently awaiting several trials in the first-line setting as we speak. So where do we move from here? So moving forwards, we are embarking on a new initiative called Starlight, which we hope to really extend these findings to other rare cancers, with a particular interest to find clinically actionable targets for precision oncology practice. And in angiosarcomas specifically, we hope to attract clinical trial support for our local patients. So with that, I would like to thank the many people who have made this work possible. And if you're interested, please feel free to visit our social media page. All right, thank you, everybody.
Fantastic. Thank you very much, Jason. It was a wonderful talk. And we've actually got some questions in the Q&A box. Professor Herbert Loong, thank you for coming to join us. And of course, Herbert's first comment was excellent talk, Jason. But Herbert has a question as well. Is there any reason why it is in the Asian population that UV radiation is a major contributor to tumorigenesis and not in other populations? Are we preemptively at risk? This is in a way counterintuitive, though, as we also have a much lower rate of superficial melanomas.
Right. Thanks, Dr. Herbert, for joining us today and for the great question. Well, I think it's a really tough question to answer, right? Because this is such a rare tumor, and really we're only starting to scratch the surface of the genomic landscape. But I think in terms of ultraviolet signatures, we have seen the data presented in the Nature Medicine paper from the Broad Institute, and even in their series of cases, we do see that their head and neck angiosarcomas, at least a subpopulation of them, do carry the ultraviolet signatures as well. Though it may not be as high as what we see from our own series. Whether this is a real finding or is it due to some methodological differences, I think that remains to be seen. But I think certainly because the tumors are in the head and neck region, previous exposure to UV certainly is an important risk factor, and perhaps it could also be something that is potentially preventable through education, sun screening, as well as any other skin cancers. So the situation gets more complex as well as we start to also look at the other risk factors, like the immune response and also the exposure to viruses. So how this impacts on how important each component is to the eventual development of angiosarcomas. I think this is really an important question that we need to tackle at the molecular level and also perhaps on a more global epidemiological level. Yeah.
Thanks, Jason. I think in line with that comment on UV, Rustin has a comment as well. Anecdotally, I feel that AS arises on sun-exposed skin of fairer-skinned Asians. In my limited experiences as Rustin's, I've never seen it in a Malay or Indian patient. Perhaps more pigments in skin are protective. What do you think, Jason?
Yeah, this is interesting. Of course, we may have a referral bias, I guess, in our population, most Chinese and fairer skin. And actually, this particular question has also been asked many times in the melanoma field. And for a long time, there have been really, a suspicion of ethnic differences, right? And I think whether the pigments themselves are protective or in fact confer a risk, I think this is still unknown. And perhaps, we could always design a larger study to look at ethnic differences in Singapore. Then again, with so many risk factors, including the HHV7 story, how the host immune response, including the HLA subtypes, polymorphisms, and how they impact on their eventual disease occurrence. I think these are really complex questions that we cannot answer, especially in a single institute study. So hopefully we get more interest and more chances to collaborate with everyone across Asia and with Europe and US, and we can do really, hopefully we can answer these important questions. Yeah.
Thanks, Jason. And I think there's a few other questions and comments, and Farid has his hand up, but I'm just going to go to Prof. Robert Markey's comments in the chat group for panelists as well, because just in case Prof. Markey has to rush off, he might even be already en route on the train. Prof. Markey says, great talk, Jason. I hope you can spin this work as a very high visibility paper. Or 3, look at the cottage industry that has been built up around Merkel cell, for example. Can you find the full integrated viral genome in angiosarcomas? Can anti-HSV agents be used in that subset? Yeah, I think Dr. Markey looks like he's at the train station.
Yeah, thanks. Thanks, Dr. Markey. Yeah, so great comment and fantastic question. So full integrated viral genome in angiosarcomas. So this question has come up so many times in the last 10 years, and it is really challenging to find the integration site. We have actually published some initial data to support at least a couple of integration sites in the human genome. This is in the JCI paper published 2 years ago. But then again, I think it is still very preliminary data, and most of the, I would say, experts in the field still cast their doubts, and we're still doing much work on it. And we may have some new data that we are presenting at the AACR in April. So hopefully we can share more at that time. Yeah.
Thank you, Jason. I hope that answers your comment and question, Prof. Maki. Yeah, all right, great. Farid, you had your hand up. Did you want to ask something? No?
Yeah,
Yeah.
thanks for a great talk, Jason. I mean, two questions actually. One is I find it interesting the issue about the virally induced angiosarcomas that we saw seem to be in patients who have a lot of inflammatory cells, immune cells in them, right? But at the same time, the postulation is that sort of immunosenescence or immunodeficiency of some sort leads to development of virally caused cancers. I mean, how do you resolve? Maybe I'm being too simplistic in the way I think about the immune system, but how do you resolve that seeming paradox? And the second question is, are these biomarkers ready for prime time? If so, why are we not integrating them into clinical studies? I mean, I think that's basically what needs to be done, right? Yeah.
Thanks, Farid. Yeah, those are extremely difficult questions. The first question, especially, I think nobody would have a good answer for that now. Especially for angiosarcomas, it really takes a long time to do a proper study, at least from a single institution point of view. What we have tried to look at is whether there are correlations with immunodeficiencies or at least with age that may correlate with some kind of immunosenescence, but we did not find such an association. But then again, what is immunosenescence? Whether the markers that we use now are really reflective of the different levels of immunosenescence or immunodeficiencies in the patients, I think those are really difficult questions to answer. But I think to do that, we really need to do a proper prospective study collecting blood, tumors, comprehensive genomic profiling, and I think it would take at least a decade to answer that kind of question. The second question is a little bit easier to answer, perhaps. For me, I think for rare tumors, we really should do as much as we can to really get as much information as we can on a really every case that comes by as much as possible. And for angiosarcomas, I think there is perhaps I would say good enough data from a rare cancer point of view. Already so many case reports, case series that have been published correlating high TMB UV signatures. And from a pan cancer point of view, the high tumor inflammation scores have been correlated with high chances of response to checkpoint blockade. And sometimes this data is already being incorporated into the molecular tumor board. But for rare cancers, I guess the difficulty is always with funding because these are not funded, by the government. Medishield, Medisave funding that we get for Singaporeans, and we do need to come up with a better way to, do this for all the patients that walk through our door. Yeah.
Thanks, Jason. Johnny has his hand up, but Johnny, before I go to you, if you don't mind, we'll take some of the questions from the floor. Dr. Kon Yew Kwek, many thanks for the comprehensive talk, Dr. Chan. May I know your thoughts on the combination of ICI with RT, please?
I believe that currently we do not have any published data, or at least as far as I know. For ICI therapy, I think there certainly is room to combine with RT, especially if you're talking about stimulating neoantigens and getting a better response to checkpoint immune blockade. So I think as per most other tumor types, I think this is perhaps the way to go, but I think we are awaiting clinical trial data to answer this more confidently. Yeah.
Okay. Thanks, Jason. And there's a question from our colleague, Dr. Natasha Putri. Hi, Jason. Is there any difference in treatment strategy for primary versus RT-related head and neck angiosarcomas?
As far as I know, I don't think so. I think for localized tumors, certainly the primary therapy will still be the way to cure these tumors would definitely still be a surgical approach. whether to give radiation or not to these RT-related head and neck tumors. I think this is really a question to be debated at the tumor board. But I think in our own local series, we do not really see any, if I'm not wrong, of any RT-related head and neck angiosarcomas. Most of the cases, about 2/3 of them, are actually arising from the breast after mastectomy and post-mastectomy radiation. And the other group seem to be more in the abdominal region after some kind of radiation after cervical cancer, for example. So for RT-related head and neck cancers, angiosarcomas, well, I do not know of any particular series focused on this area. Yeah, but yeah, I guess at the moment there would not be a big difference in the primary treatment strategy. Yeah.
Great, thank you, Jason. And one last question on the Q&A box before we go to Johnny from Pradeep Chetri. Thank you, Dr. Jason, for the great talk. Is angiosarcoma more difficult to diagnose as compared to other cancers of similar category? If yes, what can be done to diagnose it early?
Okay, well, I think sarcomas in general are may be difficult to diagnose. And in general, we do send all our cases through an expert sarcoma pathologist for review. And for angiosarcomas in particular, sometimes they can be difficult to diagnose if, especially for complex areas, if they're in the heart, in the pulmonary vessels, they can be confused with other vascular sarcomas. In younger patients, sometimes just received a referral yesterday from a young guy with angiosarcoma, suspected angiosarcoma in the ear canal. This is in a 16-year-old. It's highly unusual, and sometimes I think as with all sarcomas, the clinical context is very important, and I would best defer this kind of question to an expert pathologist, and also this proper discussion in MDT. Yeah.
Okay, fantastic, Jason. And Johnny, over to you. Johnny has a question.
Yeah. Thanks, Val. Jason, I mean, we have spoken about this on various occasions, and I must say that every time I see a different version of the talk, I really enjoy it. There's always so much more data that adds on. Again, congrats on all the good work. Among all the projects and all the people that's working on specific topics in sarcomas, I must say that your work on angiosarcoma is really quite progressive in the sense that it keeps coming out with more and more information. Now, I have a quite a pointed question that will probably may or may not have an answer, right? And I would like to stimulate some discussion from the rest of us as well. As you can see from the number of questions that comes at you, they are all different questions about angiosarcomas in different perspectives, I would say, in terms of diagnosis, prognostications, treatments, immunotherapies, and all that. When we have, now that you have gained a lot of data on understanding, and obviously you can get much more information, what is one overarching direction that you feel will be a lighthouse for all of us working on rare tumors, be it whatever that we choose, that sort of gives you a clear direction that it will give you the biggest benefits for angiosarcoma, while at the same time giving us enough parameters to have all these side projects? So if I were to ask you, what is your one biggest question that you will take in the next 5 years that you can answer for something now that you have such great success, in angiosarcoma? So I don't know whether if that makes sense and whether it's answerable, but do share your comments, please.
Thanks, Johnny. And yeah, anyone please feel free to chime in as well. That's a tough question from Johnny. What is the direction forward in the next 5 years? It feels like an interview question, but I think what we are trying to do for rare cancers again is to get as much data as possible, not only for angiosarcomas, but for any rare cancer, right? Because for so many patients who walk through our door with this weird diagnosis on the table, when we go to PubMed, there's no data. They ask us questions, we ask the same questions back to them. And what I feel we should do is really to get as much data from them at the molecular genetic level as possible. At our center, I think there are efforts all around to get this kind of data up. And there are also efforts moving the next 5 years from our group to profile all these rare cancers for each and every one of them. Of course, funding is a big issue. And second issue is to how to match this data to kind of like direct clinical benefit to the patients. So to do that, I think pharma support is very important, because every time we profile a tumor, there's like so many targets, and each target is matched to a different drug. And how do we get that? How do we get the support, from so many pharma companies for so many drugs? I think those are really unanswered questions, and we really have to work not only within the sarcoma team, but also with the clinical trial group and other groups in our center as well. Yeah. Perhaps we could hear from Val, Farid as well.
Farid, what do you think?
I don't think I have anything very valuable to add to that. I mean, I think, but if I could maybe just what Johnny's, but I'm just trying to sort of paraphrase what Johnny's trying to ask. Basically, the scientific guidepost, you know what I mean? I think maybe Johnny, that's what Johnny's trying to ask, to try and reach for people working in at the bleeding edge of translational science in rare cancers. You know, I mean, clearly, yeah, what you're talking about, access to drugs, etc., and all that is highly important. But I think the question is, how do you frame that question, right? Because I think in angiosarcomas, the slight Asian predilection, the suspicion, hypothesis about viral etiology was I think a good foothold. You know, I mean, and then the next, what's the next, what's the next lighthouse or guidepost to take you to the next level? You know, I mean, I think that's what he's trying to get at.
Just to be quite audacious in this ambitions, do you think that, Jason, you should be setting up a center for angiosarcoma diagnosis and treatment and be the subject matter expert, gathering every single piece of information in the world so that everybody, because it's such a rare tumor, they will then come to this center where you get the expert opinions from everybody? Because you see, there are still many silos of people working on different rare tumors, even including angiosarcomas. You see, and this information are in all different parts of the world. They are obviously not even in the guideline, for example. You see, so the way that perhaps I would maybe say is that the biggest benefit is really to have a clear, amalgamated guidelines for something like this, given the amount of work that you have done at the translational front, and knowing what we have currently with an armamentarium that we have in NCC or in any other cancer centers. But it's obviously a very ambitious sort of aim. But this is something that we think about all the time. We want to have a lighthouse like in 10 years time. This is what I want to go for. And the rest of it is just a little bit of noise, a little bit of good stuff, a little bit of information that would add to the biggest picture. But this is what I feel. I just wanted to see what the rest thought about something like this.
I noticed that Prof. Maki wants to say something. Yeah, and I think it would be great to hear from you, Prof. Maki.
I hope this transmits. But is there the
we can hear you.
possibility of setting up, is there a way of setting up a Corey Painter-like hub for, for materials across the region? And that would serve as a really unique resource that's hard to replicate. You already have the roots for that already, and it seems like it's something we really have to build on. And there's certainly enough cases in the region to be able to do so. And the same could apply for a clinical trial, right? You could, if there's a way of engaging industry to help support a study across 5 or 6 countries, then you've got all the parts that you need, and then perhaps industry can also help support getting the materials to you for that analysis.
Fantastic, Prof. Maki. I think, one of the, in a way, one of the things we hope to achieve through, forums like this really is to encourage collaboration, not just within Singapore, but also internationally. And so I think, this perhaps could be the start of a wonderful new collaboration, with perhaps places in the US and through links to Prof. Maki to further the angiosarcoma effort in Singapore.
Count me in.
Fantastic. Thank you, Prof. Maki. Yeah. Jason, what do you think of that?
Yeah, great. Of course, we also won't forget our friends in the region. I guess we also want to start in Asia. We
Absolutely.
have Dr. Herbert as well with us today. So if you're
Yes.
hearing this, I think perhaps it's time for more in-depth discussion to revive what we can do, even within Asia, and then collaborate with the rest of the world.
Yeah, absolutely. And of course, Herbert is from the Chinese University of Hong Kong. Thank you, Herbert, for coming on as well. And one last question from Dr. Wong Ru Sin, Jason. Any empirical evidence for PI3K inhibitors in RT-related breast angiosarcomas?
Well, this I'm not aware at the moment. Perhaps there may be clinical trials that are ongoing, but as far as I'm aware, since the data that have been published, I'm not sure if there are already some case reports or series that reported responders. Yeah.
Okay. Great. Thank you, Jason. Hope that answers your question, Rusin. And thank you everybody for the wonderful discussion, and Jason once again for the wonderful talk. We're now going to move on, if that's okay, to our next speaker, Dr. Farid Mohammed. So let me just share my screen as well. Yeah, hope everybody can see this. Great. So our next speaker is Dr. Farid Mohammed, who is a wonderful colleague, a friend, and also a wonderful mentor to many of us. Thank you, Farid, for answering our many endless clinical questions when it comes to managing rare tumors and sarcomas. Farid is a senior consultant medical oncologist who subspecializes in the management of sarcomas and melanomas. His clinical research interests center around exploring techniques to optimize clinical decision-making in the management of rare tumors, evaluation and implementation of value metrics in cancer care, as well as enhancing clinical services for adolescent and young adult cancer patients. So today his talk is very exciting. It's entitled Adopting Novel Approaches in Rare Cancers, How Much Evidence is Sufficient? Thank you, and over to you, Farid.
Thanks, Val. Let me just share screen. All right. Okay, thank you, everyone. Thank you, Valerie. Thanks for the opportunity to speak today. Yeah, so she's mentioned the title of my talk. It's going to be very different to Jason's talk. There's no high-powered science, just a lot of some philosophical musings, tentative thoughts, and very preliminary suggestions around clinical practice. Certainly a daunting topic. It's very contentious, I would say, very large topic, but I'll try my best with a focus around novel systemic therapies in sarcoma specifically. Apologies, just give me a minute. Okay, so I thought I'd just start off by outlining the different elements of our general approach, a general clinical approach, and see where evidence, the big piece in this title is where does, how much evidence is enough, right? So where does evidence fit in? I think we all start with data. All of us, we start with looking at data. And when we talk about looking at data, I think we all agree that everyone needs tools, skills, and postures to thoroughly and critically evaluate data. What I mean by postures is basically having a healthy skepticism and critical eye when evaluating studies, but at the same time being open to novel approaches to answering clinical questions. And that's obviously very important in rare cancers. Then it comes, we talk about who consumes this data, relevant to the clinical space. We talk about the healthcare practitioners, oncologists, surgeons, etc. And then there are professional organizations, NCCN, ASCO, what have you. And then there are regulators. And this can be thought of as a community, or sometimes perhaps a hierarchy, right, of appraisers, because rightly or wrongly, the appraisals of some group are sometimes deemed more valid or more important than that of others. And with this data, we then try to make clinical decisions, and there are also many different pieces to clinical decisions. First and foremost, when we make decisions, it's not just, we don't just use, scientific principles, because obviously we're treating human patients, there are humanitarian principles to think about. And of course, there are legal dimensions to clinical practice, malpractice, etc. So that's one piece when you talk about decisions. Then there is the huge issue of noise, which plagues all the the professions where judgment is exercised. Sometimes decisions are not reproducible, they're not consistent between practitioners, even within practitioners, and this has been shown to be a large source of error over and above bias. So obviously, this is a huge part of decision making. And perhaps most importantly, there's the issue of communication. Communicating risk and uncertainty to patients as we make a shared decision in their clinical care. And this is especially so in rare cancers because sometimes, let alone let's not even talk about prognosis and the treatment algorithms, but sometimes even diagnosis is uncertain for very rare cancers. So the communication of this risk and uncertainty is extremely important. So where does evidence fit in? Well, I think evidence fits in somewhere in between. This process of absorbing and consuming and interpreting data and making decisions. And I wanted to just at this point mention a little bit about this distinction we sometimes make between facts and values. I mean, in science and medicine, there's a tradition of trying to separate facts from values. Facts are objective, descriptive things, while values are subjective, infused with human ideals and principles. And obviously, this is of relevance to evidence and its application. Let's find out the facts and then let's apply our values. But as I'll try and sort of talk about a little bit more through this talk, this distinction may sometimes be difficult to apply in practice because the demarcation can be quite leaky. Facts are entwined and entangled with values, and this is something we may need to recognize. And at the end of our decision making, then we look at outcomes, right? And when it comes to that, obviously it's important to try and elucidate and figure out what are the causal factors that led to a particular outcome. And sometimes not easy. Obviously, there are many different causes that can work in many different ways, sometimes not even serially, that lead to a particular outcome. And apologies. And then the other piece is trying to evaluate the quality of those decisions, preferably in an outcome independent way, because obviously we want to try not to be outcome biased, because good outcome doesn't mean good decision and vice versa. So this is kind of the template, I would say, to clinical practice, and throughout the rest of this talk, I'll try and work off this template with regards to evidence in rare cancers, and I'll come back to this slide right at the end with one or two closing thoughts. I think every one of us is familiar with the hierarchy of evidence in the sort of evidence-based medicine (EBM) paradigm. Right at the top, you've got systematic reviews of randomized trials, observational studies, expert opinion, and then just mechanism-based reasoning. But if I were to whittle it down, I think evidence boils down to three main things. First and foremost, it needs to be real. It needs to be valid. It needs to be real. I mean, if we find an effect, we need to be convinced that that effect is real and it's not invalid or it's not false. Usually, and the commonest cause of which is bias, in all its different forms. So that's the first thing we need to be convinced of. And the second thing I think we need to be convinced of is that the evidence is reliable. It's something that's reproducible, that's consistent, that is not noisy in the parlance of data science. And the third and probably maybe the most important part of it is, even if you have valid and reliable data, why should we care? What does it matter? There's this issue of value, which I think is an important piece in the interpretation of application of evidence, that is sometimes not so easy to figure out and to convince ourselves, let alone patients, of. So that's kind of how I would think about evidence. And as regards rare cancers, well, just the different definitions, but this is data from Rare Cancers Europe. One definition is cancers that affect less than 6 per 100,000 people, in the population. And although these individual cancers are rare, the collective burden of individually rare cancer is actually quite large, up to a quarter of cases in Europe, including obviously all cancers in children. And you can see where sarcoma fits into the schema, at least in Europe. It's about 7.5% of rare cancers as such. And I think these problems that I've highlighted in this slide are some things that are very easy to understand and common to a lot of rare cancers. Diagnostic delays, lack of access to appropriate treatment and expertise. Companies find it not commercially viable to develop new treatments. Difficulty in conducting well-powered clinical studies, obviously, because they are uncommon, and few available tissue banks, which I think Jason alluded to as well. So we are faced here right from the word go with this difficult trade-off, this difficult balance we need to strike between protecting patients and society from ineffective and low-value treatments, which I think is obviously of critical importance, and protecting patients and society from perhaps unjust and inequitable reduced access to effective treatments. Patients shouldn't have to suffer just because their diseases are uncommon. So this is obviously a difficult trade-off. And how has this trade-off been negotiated in the sarcoma world? I'll try and talk about that a little bit, and then try and give some thoughts, my personal thoughts towards the end. One big piece of this is through legislation and sort of policy, what I call prevalence-based prioritarianism. Some legislation in the US and the UK, for example, the Orphan Drug Act, which provides funding and contracts to perform clinical trials to incentivize drug development and clinical research in rare cancers. You can see that there's tax credits, marketing rights, etc. So financial and sort of material incentives to pursue research in rare cancers. And then in the health technology assessment space, obviously the most preeminent organization for that is the National Institute of Care Excellence in the UK. There is also some prioritarianism for very rare diseases. So the threshold for willingness to pay for cost effectiveness analysis is arbitrarily set much higher for very rare diseases. So there are already policies in place to try and incentivize research and access to treatment for very rare diseases. But do these measures work? Well, on one metric they do. You can see that this is data showing that over the years, the number of orphan drugs which achieve FDA status for orphan diseases, which is designated as orphan diseases, has been increasing gradually over the years. But if you look at the data carefully, this is just the drugs that were approved, FDA approved for tumors that were designated as orphan tumors in 2017, for solid tumors at least, in 2017 that was designated as orphan tumors. And you can clearly see that these are clearly not what you probably first think of as rare cancers, right? Because they're essentially subsets of common epithelial cancers and some lymphomas, which shows you obviously the unintended consequences of providing incentives in this manner, right? We have a lot of orphan drugs approved, but are we really optimizing access and treatment for patients with rare diseases? That's obviously something that needs to be dissected and thought about carefully. And all policies will have unintended consequences. Just 1 minute. Yeah. Okay. So in the ideal situation, what we want a situation where we have level 1, very high quality evidence, which you can see on the left of the screen. Randomized controlled trials to look at efficacy under very controlled conditions, to get excellent internal validity, and you look at certain metrics, and then combine that with less rigorous studies, which have probably or possibly better generalizability, external validity. You look at the same outcome metrics and then use them to inform regulatory decisions, clinical decisions, and health technology assessments for reimbursement, obviously. And in this bag of less rigorous evidence, I mean, probably the term that's most in vogue nowadays is real world evidence, which I'll talk a bit in a bit more detail about later. Essentially referring to observational studies usually, but there are other sources of evidence. We can look at randomized phase 2 studies, single arm phase 2 studies, adaptive trial designs, basket umbrella trials, all with different levels of different sizes, different levels of validity, but all sort of helping us hopefully to make better decisions in the end. So what I'm going to do next is I'm going to look at a bunch of these studies in recent times for novel drugs in sarcomas, and then try and give an assessment of where they stand. So I'll first start talking about olaratumab. Essentially, for those who are unfamiliar, I mean, it's a platelet-derived growth factor receptor monoclonal antibody against a platelet-derived growth factor receptor that was studied across all subtypes of soft tissue sarcomas. It was combined with doxorubicin, compared against doxorubicin in a randomized phase 2 study. It showed very promising activity, essentially improved survival benefit, very impressive survival benefit, but probably significantly less impressive progression-free survival benefit, which on hindsight probably should have been a sign that the results may be a little bit, there may be some issues with the results, which eventually panned out. The results were not replicated in the follow-up phase 3 study. So this drug was given FDA accelerated approval based on the phase 2 study, but which was subsequently withdrawn after the confirmatory study did not show the efficacy result. So a lot of lessons to be drawn from this incident. I mean, I'll just probably highlight one, which is I think important to bear in mind, and the issue of crossover. When we do clinical studies, because in the phase 2 study, actually, when you look at it, a higher number of patients in the experimental arm got active second-line treatments compared with the control arm. A large proportion of whom received olaratumab, because in the control arm, if they progressed, they got access to olaratumab. On crossover, which is an unproven treatment post-progression. So usually when we talk about the problems with crossover, we say that if you have an effective experimental treatment, overall survival benefit can be masked when the control arm crosses over to the effective treatment. But the converse is also true. If the experimental treatment is ineffective, then you can have a false demonstration of efficacy of the experimental arm, because the control arm that crosses over to the ineffective experimental arm actually does worse, compared to the experimental arm in the post-progression setting. So this is something that I think is a good learning point from this study. CDK4 inhibitors in well-diffused liposarcoma. I mean, this is actually quite old data. I think most people in this audience will be aware that virtually all well-diffused liposarcs have the 12q chromosome amplicon that results in upregulated activity of MDM2 and CDK4, which repress two very prominent tumor suppressors. So upregulation of these two genes obviously will cause oncogenic effects, decreased apoptosis and increased cell survival and proliferation. So biological rationale seems reasonable, but the clinical data, unfortunately, was not very impressive. I mean, single arm phase 2 of palbociclib, which obviously has demonstrated great success in breast cancer, hormone-positive breast cancer, showed very few RECIST responses. And this drug is not FDA approved in the use of well-diffused liposarcs, although it is listed as an option in the NCCN guidelines, which speaks to the what I was talking about earlier, right? The hierarchy of consumers of the data, between regulators, organizations, clinicians, and where sometimes there can be discordance in the evaluation or the assessment of evidence. I think it's impossible to give a cancer talk these days without touching a little bit on immunotherapy. And of course, many studies done in different types of sarcomas, but just pulled out a sort of study across all sarcoma subtypes, single arm phase 2, which showed, possibly some signal in certain tumor types, DDIF liposarc and UPS. But I think an expansion cohort in those particular subtypes, UPS and liposarc, showed, at least in the liposarc group, that the activity was not very impressive. Maybe some signal in undifferentiated pleomorphic liposarcoma. So immunotherapy is obviously a huge topic. I mean, regardless of it's not FDA approved for sarcomas in general, in a histology agnostic way across all sarcomas. But of course, it does have approval in a histology agnostic way when the tumors have specific biomarkers, high TMB or high microsatellite instability, but not at this moment across all sarcomas without those particular biomarkers. Now, these are obviously quite interesting. Tenosynovial giant cell tumors, PVNS, they're basically conditions with features of both inflammatory disorders and clonal neoplastic proliferations, essentially characterized in most cases by a translocation that leads to upregulation of CSF1, colony stimulating factor 1 in the neoplastic cells, which are in the minority. But because CSF1 is upregulated, they recruit non-neoplastic inflammatory cells which express the receptor, causing a large mass composed primarily of non-neoplastic cells, not unlike Hodgkin's lymphoma, I guess. And for the longest time, systemically, we've been using imatinib, which has some activity against CSF1 receptor, but recently an inhibitor, a specific inhibitor of CSF1 was developed and validated in a randomized phase 3 study, not a very large one, but in a randomized phase 3 study, which showed very good activity. Although I think initially there were some concerns about toxicity, specifically liver toxicity, which obviously for cancer that has sort of intermediate biology, doesn't metastasize, doesn't cause mortality, is extremely important. The risk benefit of toxicity needs to be very, very carefully weighed. So anyway, this drug is FDA approved for the use of in tenosynovial giant cell tumors. This is, of course, probably one of the most exciting developments in oncology in recent years. Although it afflicts only a small proportion of patients. TRK inhibition. Essentially, TRK fusion is found in a small proportion of all cancers, very, very small percentage of all cancers, and in a somewhat larger proportion of certain histologic subtypes. And data across all tumor types show activity when you have the TRK fusion, leading to the approval of this drug as a histology agnostic treatment. One of the very few histology agnostic treatments, in fact, probably the only histology agnostic treatment, with a kinase against a genomic aberration. The other two, if I don't remember wrongly, are only immunotherapy with specific biomarkers. And you can see the outcomes in sarcoma specifically, extremely impressive response rates and very exciting durations of disease control and overall survival. Although the main problem with TRK inhibition is that NTRK is rare, it's a rare aberration, and just how do we go about figuring it out, whom to test in sarcomas? One way is to try and have a three-pronged approach, essentially, which I think this was taken off some guidelines published in Annals of Oncology last year, which we've also adopted in our regional sort of guidelines. Essentially, sarcomas that are known to be enriched for NTRK fusions, infantile fibrosarcoma and inflammatory myofibroblastic tumor, we immediately test using molecular diagnostics. The complex genomic sarcomas which have a low frequency of NTRK fusions, we screen with IHC, and the translocation or recurrent genetic aberration sarcomas, generally thought not to have NTRK fusions, because these genomic aberrations are thought to be mutually exclusive. So the recommendation is that NTRK it shouldn't be a routine evaluation in these tumors. So anyway, FDA approved in his histology agnostic fashion, and you know, very impressive data from a basket trial, basically, essentially a single arm phase 2. We've talked about briefly about epigenetics earlier. Well, you know, the epigenome is obviously dysregulated in many cancers. You know, the epigenome is so important in directing the structure and function of the genome and expression and repression of particular genes. In the particular case of relevant to this, INI1, which is a component of the SWI/SNF complex, is a tumor suppressor that exerts an inhibitory effect on EZH2, which, you know, when upregulated, when you have INI1 deficiency, leads to, you know, oncogenic signal transduction. So INI1 deficient sarcomas, like epithelioid sarcoma, this was tested in epithelioid sarcomas in a basket study, single arm phase 2, essentially, with, you know, I would say fairly modest results, for which it was given accelerated approval by the FDA. Interestingly, for this particular approval, real world evidence was submitted to the FDA as part of the approval process. Essentially, a retrospective chart review of a bunch of patients with epithelioid sarcomas. And you know, it's interesting. I mean, the FDA comments with regards to the use of real world evidence for this submission was that essentially they didn't think it was very impressive. You know, the protocol did not provide adequate detail on the quality of data. Study population did not match the trial and factors, including inclusion criteria. You can see some imbalances in the subtypes of epithelioid sarcomas. You know, I think a larger number of probably the more aggressive proximal subtype in the real world evidence. Obviously, it's hard to fault the investigators given this is such a rare cancer. But anyway, I was just trying to mention about how real world evidence is now being incorporated into submissions to the FDA, although they don't always serve the intended effect. So this drug has accelerated approval, which means that just like with loritumab, there needs to be confirmatory evidence of its efficacy, without which it may be withdrawn. I think this is the last drug I'll be talking about. You know, PICOMAS, perivascular epithelioid cell tumors, interesting types of cancers, which the large majority of which are sort of driven by the tuberous sclerosis complex gene, which lends itself to abrogation by mTOR inhibitors, which we've been using in clinical practice for quite a long time. But nebulized sirolimus, essentially nanoparticle albumin-bound sirolimus, is thought to have significantly higher tumor growth inhibition, intratumoral drug accumulation, and target suppression than the oral formulation, or, you know, like sirolimus, which has variable absorption and lower target suppression. So the phase 2, again, single arm phase 2 data, okay, small numbers, decent results, which to be sure are not that dissimilar from retrospective data on good old sirolimus or everolimus, but obviously these are prospective data. And this was also recently FDA approved for the treatment of PICOMAS. So let's take a look at the drugs that we have. Essentially, we have you know, a bunch of drugs. They all have a well-defined mechanism of action, but they were not all of them were applied to a specifically biomarker-enriched population, which may have led to some problems, I think, in their development and their approval. Most of the studies were randomized phase 2s or single-arm phase 2s. Real evidence was used in a submission for tazemetostat, and yeah, this is kind of a variable record on FDA approval. One was approved so two had accelerated approval. One has already been withdrawn. Accelerated approval is one of the types of expedited approval that, as I said, usually based on a surrogate endpoint, and full continued approval is subject to data from confirmatory trials. So if you ask me personally, I think that the slam dunk is probably the main will be NTRK inhibition. I think The responses are deep. Even from the data that we see, the biological rationale obviously is strong. The responses are excellent, quite deep, even from the short follow-up that we have. And we do have some idea that these drugs are not, because the key question usually with biomarker enriched single arm studies with no control is how do these cancers do in the absence of this treatment, right? I mean, perhaps they are prognostically already quite good, but that doesn't seem to be the case with N-teractubas, at least from the data that we have. So I think that's probably the one that I would say personally is very convincing. I think the other drugs, the ones which are not FDA approved, I would agree. The ones which are FDA approved, I think the jury's still out. Most of them are still very preliminary. There's certainly useful options to have, but I think a lot of unique factors to patients, values, etc. Reimbursement decisions will come into play when we decide on the use of these therapies. I just wanted to talk a little bit about real world evidence. We talked about a lot these days. What exactly is real world evidence? Well, it's a catch-all phrase for non-randomized studies, essentially, usually retrospective or observational data. But it's quite important to try and not use this term to sort of inadvertently validate weak or low quality data. I think that's important to bear in mind. I mean, just showing some data. I mean, for example, this paper which looked at observational studies from national databases compared against randomized controlled trials, both comparing two treatments for cancer. And you can see that the hazard ratios are very poorly correlated. The correlation coefficient is 0.128. So the data from the real world studies don't actually track the data from the randomized trials. Again, another study that shows, again, real world data, the vast majority of which was assessed to be of low quality for FDA approved drugs for non-curative treatment. And when you compare, again, the median survivals against the pivotal studies, you see a very wide separation for a lot of the drugs. Large differences between the real world results and the randomized trials. And also from this study, it was shown that the lower quality real world studies tended to inflate or give very favorable results compared to the much more favorable than the pivotal studies as compared with the higher quality studies. So I think it's very important to bear in mind that real world evidence, at the end of the day, what matters is the quality of the data. I mean, just because it's real world doesn't mean it's useful or data. I always thought, and since we have a broad audience today, including junior doctors, I think it's important to always emphasize this. One of the lowest hanging fruit making good decisions beyond evidence is just I would say a reasonable, clinically oriented approach, which I think is the easiest thing to do. Just a story about a patient of mine, a young lady with a malignant pleural effusion whose treatment was delayed because everybody was struggling to try and figure out what cancer she had. Nobody could subtype it. It went all over the world. It took 4 months, and by the time she saw us, she needed to be intubated. She was in respiratory failure, which I thought was extremely tragic. And I at the end of the day, like I always tell the residents, we just want to know whether it's cancer, whether we can be cured, which obviously we don't want to miss, and whether it's treatable. Because getting an unassailable diagnosis, if the one exists, it's great, but it's useless. Obviously, the patient is dead. It doesn't take much to recognize, an aggressive tumor, and we certainly need to communicate better. I mean, I just put this in to try and emphasize that sometimes being fixated on evidence and its quality, takes us, distracts us from some of the very, very basic things I think which are important. In clinical care. I think I may get some flack for this slide. It's very provocative, but it's something I've thought about before, and just to put it out there, and happy to hear people's thoughts as well. Sarcomas are always talked about as being very heterogeneous, complicated, difficult pathology, etc. And I just put two famous scientists on the side there in talking about how things are classified. Charles Darwin obviously compared biological species to constellations. Constellations being obviously an arbitrary result of our very specific base, vantage point in the solar system and in the cosmos, as opposed to something which he thought was real. And Ernest Rutherford, obviously the atomic scientist, went one step further. All of science is either physics or stamp collecting. I guess he was just saying that things like chemistry, biology, it's about finding elements and species, etc., without actually getting at fundamental principles. Obviously, that's very simplistic and not correct. But I think it's worth thinking about. Perhaps I would say that with a notable exception of just the ever increasing complexity of sarcoma histologic subtyping has yet to translate into directly actionable therapeutic success. I would say NTRK is not confined to sarcoma. If we fully sort of take in the personalized medicine paradigm, even the common anatomically defined cancers are similar to sarcomas. They're not homogeneous, right? They are buckets of different subtypes. So sarcoma heterogeneity is not truly unique, and we shouldn't sort of always bring it up as something that hamstrings or that hampers progress in treatment. And this is obviously very speculative, very provocative. I've said this in one or two meetings before, and people have shot me down a few times. But yeah, I think it's something I've thought about. I think personalized medicine is great, but perhaps something that's truly transformative in cancer therapeutics would be to depersonalize it. Going beyond the particularities and constantly changing genetic makeup of individual tumors to exploit truly elemental neoplastic dependencies universally, like a cytotoxics 2.0 that goes beyond arresting cell replication. Obviously immunotherapy was thought to be just this, but there are problems with immunotherapy, and perhaps such an all-conquering approach will forever be out of our reach due to the inherent diversity and dynamism of tumors. But I think even if that's the case, we should not diminish, it should not diminish the rigor with which we assess the impact of current paradigms, including personalized or precision medicine. I'm finishing up here already, and I think the last one or two things I wanted to say is that, of course, there are many philosophical issues that we need to talk about when we talk about evidence in rare cancers, or indeed in medicine, right? Because firstly, do our unspoken epistemic values stand up to scrutiny? These are the values that we subconsciously apply to help us make decisions in the clinic, at tumor boards. Values like simplicity, coherence with other theories, and explanatory power. We use that routinely. Perhaps it's something we should think about. Is our duty of care to individual patients or to the wider society? This obviously things like, is medicine a commodity or a public good? This speaks to the tension between the supposed efficiency that markets and profits provide against equity for what is widely regarded as a human right, which is healthcare. Should identified lives be prioritized over statistical lives? And how do we construct and operationalize rigorous conceptions of value? Obviously, individuals have varying risk appetites, different conceptions of value, but medicine works through risk pooling, universal healthcare access. That means that we need to judge for others and come up with something that we can all agree on. What truly is valuable, and that would certainly make clinical practice a lot easier. And the other thing, which is I think becoming more and more, which is going to be more and more important in the coming years, should we just chuck out mechanism, hypothesis-based science in favor of just throwing everything into machine learning, getting black box predictions, which are often superior, and just use that to predict clinical outcomes. I guess this goes to the very core of what constitutes scientific evidence, which I think other fields have been grappling, like mathematics, etc., have been grappling with for 1 or 2 decades, but I think will come more and more into prominence in medicine in the coming years. My second last slide, I would say that the use of alternative study techniques to study rare cancers should be explored judiciously and appraised critically. The existence of one specific unassailable approach is unlikely, and the nimble and pluralistic posture we require should not compromise basic principles of validity, reliability, and value. beyond evaluating novel approaches, it may be prudent to substantively revisit simple things, thoughtful and conscientious clinical care, and things which we take for granted, the sacred cows, the complexity of sarcoma, nosology, and theranostics to improve outcomes. The generation, interpretation, and application of evidence in clinical oncology involves appeal to and application of often barely discernible underlying values, and interrogating and clarifying these, is of ever greater importance in rare cancers. So I go back to this slide, data, decisions, and outcomes, and I just wanted to leave everyone, with a picture, from which I take a lot usually, but the thing that I encapsulated by this picture, at least to me, is the need for humility. Obviously, this picture depicts Niels Bohr and Albert Einstein, obviously talking about reality and deep questions about the universe. These are the fathers of modern physics. Quantum mechanics, for which Niels Bohr is most famous for, is it's famously wonderful at making dazzlingly accurate predictions using a probabilistic approach to reality. And yet, he has the humility to say, such a thing, prediction is difficult, especially about the future. So I think it would serve us well to imbibe a similar humility about our ability to predict and indeed influence clinical outcomes, in our daily practice. Thank you very much.
Thank you, Farid, for the wonderfully insightful talk. And clearly, beyond just looking for new treatments, we need to think about how to integrate, the findings from what we get into what can eventually be applied to the patient. So that was wonderful to see your insight. While we're waiting for the audience to, chime in with some questions, perhaps maybe I get the ball rolling. You mentioned the example of olaratumab in sarcomas, and I was just wondering whether you had any thoughts about, sometimes I think apart from olaratumab, there were other examples where basically we saw, these spectacular results in phase 2, which shockingly, well, perhaps unshockingly, I don't know, didn't quite translate to phase 3 results. And clearly the drug was withdrawn from market later on as well. Do you have any thoughts about, what could potentially explain the discrepancies between what we might see in phase 2 and phase 3 in terms of efficacy? And a related question to that is, do you think, and obviously you're not the FDA or EMA, but apart from FDA, EMA decisions, do you personally think that we would always need a phase 3 trial before a new drug is approved? And clearly you also shared your opinion about using real world data to approve drugs as well. So happy to hear from you.
Thanks, Valerie. I mean, I think the issue about phase 2, phase 3, I mean, the simplest way to think about it, I mean, of course, it can be different specific studies have different issues, but the simplest way to think about it for me is regression to the mean. I mean, flukes are much more likely when numbers are small, because the variance is high, and your power is lower, right? I mean, so I don't know that necessarily is that surprising. I mean, so that's the first thing I would say. In fact, if you were to be technical about it, even valid, impressive results in phase 3, we don't even know whether they're reliable, right? Sometimes, I mean, but obviously that's beyond the realm of, you can't be doing repeated phase 3 studies. I mean, that obviously, but so yeah, anyway, I would just stop at that with regards to that. Do we always need, perfectly executed randomized phase 3 studies, with excellent internal validity for drug approval? No, I mean, I would say no. I mean, I think it's, first of all, foremost, clearly it's impossible. And as I said, if the signal is very, very strong, I mean, then I think it's something that should be considered. But I think this also brings into the screen the issue about post-approval surveillance, right? I mean, that's extremely important. I mean, I didn't share this, but there's a lot of accelerated approvals, and olaratumab was a good example of policy making and the approval space working well. But there are many situations when it hasn't. BEF in some solid tumors, for example. I mean, so the issue is getting the evidence, applying it, approving it, but having the nimbleness, to reverse or change approvals, etc. If the data doesn't come true. And real world evidence, I mean, people, I think, yeah, I think people feel very strongly about this. There was a paper in the New England Journal some months ago, a year ago, with by Richard Peto and a bunch of guys. Richard Peto, obviously one of the most famous epidemiologists and statisticians in the world. And it's titled "The Magic of Randomized Evidence" and the magic of randomized data and the myth of real-world evidence. Very strong feelings. I think you can tell what he feels about that. But I mean, I don't think we should always go with any data is better than no data. I mean, we shouldn't take that as gospel, because data can be nonsense, right? I mean, it can be very biased. It may not be answering the questions we want. So I would say curated and critically appraised data is obviously very useful. I mean, critically, that the moniker real world evidence doesn't validate anything. I mean, I think so that's the one thing I would say. Yeah. Drawing board.
Thanks, Farid. We've got some questions and also a comment from Jason. Jason, I'll take the question from the audience first. Murtada Abdulreda, thank you for your presentation, Doctor. What is the percentage of cases that are rare types of cancer? How can computational pathology help in such rare cancers? I suppose this is sort of a very general question across rare cancers.
Sure. Percentages, I think, briefly showed that earlier on. I mean, I think so sarcomas, 1% of all adult cancers, and 15% in the young population. Sarcomas about 7% amongst the different rare cancers, which individually less than 6 per 100,000, but collectively about a quarter of the cancer population. So that's the percentage percent. Computational pathology, yeah, absolutely. I mean, bring it on. Rise of the machines. The ghost in the machine, or whatever you want to say. I mean, I think this is something that we cannot escape. I'm personally, it's something that I think is exciting. Yet, I think the philosophy lags behind the technology, which is not always a good thing. And sometimes we dismiss the importance of grappling with the philosophy. But I feel that if there is that delay, between philosophy and technology, I think sometimes we don't quite use it as well as we should. I think I'm talking about sort of throwing data into a machine and using the algorithms that come out for prediction, which have been done for many things, and which have challenged the primacy of mechanism hypothesis-based science for a while now. So yeah, absolutely, bring it on.
Yeah, great, thanks, Farid. And I completely agree with you about AI can sometimes be a black box. But one thing to say is that I think there's also a lot more momentum now to kind of unveil the black box, to sort of go into using algorithms which make biological sense and which make rational sense in the results that we see. I think that's a good way forward too. I think Jason's got yes.
Maybe I just chime in very quickly. I mean, if you ask me personally, I think I would be more skeptical about. I would be less skeptical about the black box issue than I would about sort of real world data, etc. in general as a posture. And I say that because the black box issue is an issue, as I said, of philosophy catching up with technology. You know what I mean? That's about that, right? I mean, so we are uncomfortable with that. All right. I mean, we just need to update our, what is biologically meaningful, what is rational. I mean, all these things. The philosophy has to catch up. So we shouldn't hamper developments just because we haven't caught up. But the issue about real world evidence, etc. That's just basic. Of course, you can argue between frequentis or Bayesian approaches, but that's just basic conventional data analysis, etc. And I think sometimes it gets lost. I mean, if it's a bad retrospective study, it's a bad retrospective study, whether it's real world evidence or whatever, who cares, yeah. Sorry, Jason's comment you were saying, right? Yeah.
Yes. Actually, Farid, before I go to Jason's comment, I
Yeah.
don't know how to ask this perhaps in a way that is intelligible, that people can understand, and perhaps that you can answer. Across the sort of decades of research in cancer, so to speak, there have been multiple instances of cases where a very nicely delineated mechanism of action matched to a drug, with a supposed target, doesn't quite work and doesn't quite pan out in the results of whether it be very large phase 3 clinical trials or even real world evidence. And clearly there are so many other issues associated with why this might be the case. Do you think it is really more of an issue of the fact that it is such a complex biological system, and perhaps we shouldn't be looking at sort of very simplistic unilateral mechanisms of action, or do you think this is also hampered to a certain extent by the way in which these trials are designed, the way in which statistics are analyzed? So in other words, how important is mechanism of action, and how should we accurately use mechanism of action to develop better treatments?
Yeah. No, the first thing I will say is the last thing I mentioned in that topic. I think the need for humility is absolutely paramount. I think COVID has shown us that. I mean, every single expert has been wrong multiple times. And I think biology is so complicated. Evolution is such a in natural selection, artificial selection. These things are moving at such fast speeds. I mean, it's but the cancer is a dynamic system, right? It's not just complicated; it's dynamic. I mean, it's changing all the time, and it's a little bit like when you look at an electron, it moves the electron, right? I mean, the act of looking at it. I mean, it's not obviously not that, but when you tinker with the system, it changes it completely. And so, I mean, all those things are important, I think. But the only value add I can. So, in response to your question, is it the data analysis and data collection, or is it the fact that mechanism is not that important? I would say we shouldn't go throw the baby with a bath water. I mean, I think basically, I don't know. Maybe you're asking, if you could have a machine algorithm about drug X, Y, Z, and just that predicts activity. Forget about the mechanism and whatever. You just have a you compute the parameters, right? You can fully compute the parameters of a patient, right, or a tumor in a patient. The patient, the tumor, compute it fully. All right, then you just throw a million, even arsenic or whatever it is into the machine, and it just spits out, and it says the toxicity and the efficacy, etc. But I don't know. I mean, I don't think that's wrong. I mean, obviously, if you're doing it in a computational system, you'll get a lot of results quickly, and it's something we should think about. I don't think we should. I think that there needs to be a lot of humility. And when I say humility, I think it's also about how we think. As I said, how we think we can always influence the outcome. And I think that's something that it's hard to predict things, especially about the future.
Yeah. Thanks, Farid. Jason's comments, great talk, Farid, brings us back to the drawing board for sarcomas. How do you think we can better classify sarcomas beyond stamp collecting? Genomic molecular classification? What should be the bare minimum to be profiled for all sarcomas?
Yeah, clearly a $1 million or maybe $1 billion question. As I said, I think my approach would be to, as I said, those few pieces. I mean, I think what we're doing now is not wrong, but we shouldn't buy into its importance so wholesale. You know what I'm saying? Other pieces are also important. So I'll answer that question sort of indirectly. I'll say that the short answer obviously is I don't know. But I'll say that this whole paradigm, where we're finding out things, you see, if you have a hammer, everything will look like a nail, right? I mean, right? I mean, that's if the only tool you have is a hammer. So we have these tools. Okay, I mean that's useful and that gets us some information. But other things, like I said, clinical, uh, not acumen, but clinical oriented approach. Cancer prevention, cancer education, and also I think basic science to think about cancer, the necessary and sufficient conditions for cancer. I mean, I think that I don't know. I think that since the hallmarks of cancer, last edition was what 2011, 10 years ago. I mean, I don't see much. At least, I mean, in that direction, to see cancer as a unitary, not specifically histology agnostic treatments, but yes, I mean, not histology agnostic treatments in the form of looking for smaller and smaller, splitting it into thinner and thinner hairs, but to look at it as a whole. I mean, why can't therapeutic, viruses and bacteria can cause diseases across species and across, from bacteria all the way to whales. Why can't we target cancer in that way? Maybe cancer is not the same not the same ontogenetically, like life in that sense. But I don't know. I feel that space needs to be pushed. I mean, that's my personal feeling. Yeah.
Thank you, Farid. And there's a comment also from and question from Dr. Mark Puhindran in the panelists chat box. How do we merge all this and all this data, sometimes conflicting, and the need to get, open inverted commas, absolute diagnostic accuracy to manage the patient that is deteriorating in front of us? When do we stop and just get on with things?
Yeah, I think there's three pieces to this. First is we must look at the patient. I mean, I think it seems bizarre to say that, but I think that's important. Unfortunately, that didn't happen. The second is we need to communicate that uncertainty, and that's a huge thing. That's something that I struggled with a lot with when I first started out, and I still struggle about, because obviously patients, they don't want uncertainty, right? I mean, why would they want? I mean, I don't want uncertainty, but it's difficult. But it's something we need to come to calibrate our own ways of telling. Listen, you have some crazy thing that's growing in you. It's growing quickly. We don't really know what it is, but if we don't do this, I think it's going to cause you problems. And we have to start trying things. Which is why, again, I said broadly active things, like doxorubicin, still have their value, for this situation. And the third thing I would say is, which I don't know, I feel the need to mention it, is sometimes we shouldn't believe our own, our own story too much sometimes, right? Because we get so caught up in, does it have this fusion? Is it papillary with a different sort of formation or whatever it is? I mean, I think we need to put it all together. So we need to communicate. We need to think broadly and pan out a little bit. I think, and we need to be clinically oriented. I think. I mean, there's no simple way around it. I mean, that's what I feel. I mean, yeah.
Great, thank you, Farid. And Prof. Bob Markey actually has a question as well. And unfortunately, he can't type it into the Q&A box. Is there any place where real-world data are misleading? What counts as rigorous enough to accept as adding value? About the only situation I can easily identify is identification and tracking of toxicity. Are there others? Yeah.
No, absolutely. I mean, the moment you have a retrospective study, you have selection bias, right? I mean, it's the definition of a retrospective study, correct? So, I mean, of course, you can have fancy, propensity score weighting, yada, 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 but you will never, which is what Richard Pato was trying to establish in that New England paper, right? So that's a good point. I mean, I think if you are purist, like Richard Pato said in that New England paper, then you're right. I mean, it can never be definitive. I think real world evidence is useful to contextualize, I guess, give a baseline, of some sort. And I think if they're at the minimum, it should have, those things that I mentioned, like, I mean, those statistical techniques to matching and etc. Of course, with epithelioid sarcoma, I mean, it's so vanishingly rare. I mean, it's difficult, I think. So that's why I would say that it's tough. But in cases where real world evidence doesn't add value, we should just say it doesn't, I guess,
Yeah.
and perhaps in a non-toxicity setting for efficacy, we need to we can come up with a grade. I think there are efforts to do that now, like a grade GRADE for real world evidence. I think it was published recently in I forget the journal, not one of the high impact journals, but like a sort of a template to work around, how do we, although there are some critics who say that, real world evidence is just good old chart reviews, packaged in this little, term called real world evidence to give it more validity than it deserves, so, which we've been doing for, decades, right? I mean, I was doing chart reviews for decades. So, yeah, there needs to be a rigor. We need some consensus of what consists of some basic standards of rigor. Yeah, I mean, I think that's matching of populations, etc., to minimize bias, not eradicate, which you can't obviously.
Yeah, thanks, Farid. Actually, Prof. Maki chimed in to say he wanted to really ask where real world data is, are there examples where real world data is not misleading? What sort of scenarios?
Yeah.
Not misleading.
Yeah, exactly. So I would say, as I said, situations where we have, so if you want specific examples, I mean, I wouldn't, off the top of my head, I would say, perhaps I can't think of any examples on the top of my head, but as I said, things like back-end methods to try and redress the biases, right? I mean, there's so many techniques, right? Propensity score matching, etc. And the other piece about real world evidence, which I think is important to mention, yeah, exactly. I think this is a good example. Not in cancer, it's time. Right? I mean, I think time is a useful, but of course we're very impatient. We need results quickly. For example, if you think about it, let me just be provocative. I'll say this. For a long time, smoking was not thought to cause cancer, right? And then we still don't have randomized evidence that smoking causes cancer, right? I mean, but we have excellent observational data over a long time, 50 years, from Richard Dahl and his colleagues, Austin Hill. So we have, of course, there were conflicts of interest that tried to suppress that, tobacco industry, etc. But benefit of time and rigorous, reproducible real-world evidence. But we have only real-world evidence technically that booster vaccinations work in COVID, right? I mean, again, that's just real-world evidence, but it's real time. It's happening in real time. We have to make a decision. So values come into. Can you argue that the real evidence for boosters is misleading? Yeah, I mean, I think it is. There are some parts of it that I mean, there are biases, but then when we bring in the values that we need, we can't let things run too quickly. I mean, of course, people are dying and etc. So I mean, what I'm trying to say is, time is important, but the values are important as well, right? I mean, if you need to make decisions quickly, you may have to tune it down a little bit, I guess. Yeah. Of course, the pandemic is a once in a century event, But yeah.
Yeah. Thanks, Farid. We're running a little bit short on time, but maybe I'll just end off with a final comment that Dr. Suraya has added into the chat box as well. Dr. Suraya is one of our colleagues as well in orthopedics at SGH. A very insightful talk and discussion. Some of the rarer sarcomas, it feels like the evidence sometimes is just not robust enough yet. Not enough numbers, not enough large-scale trials, very challenging to treat. For example, one of our common patients with malignant triton. I echo Mark Windran's sentiments. Farid, do you want to add a quick comment to that before we end?
Can you hear me?
Yes.
My headphones just died. Goodness. Okay, you can hear me, yeah?
Yes.
Okay. So yeah, I completely agree. I mean, now it's come back on. Sorry about that. Apologies. Can you hear me now?
Yeah, we can.
Yeah. Okay. Sorry. Okay. Yeah. No. Absolutely. Yeah. It's just not robust enough. That's why I go back to these questions are in many ways irreducibly, to me at least, philosophical, right? You know what I mean? You have an identified life. who needs treatment, you do not know what the best treatment is because you do not have enough data. Now, because to be fair, we look at a malignant triton, as you say, as an entity, right? I mean, as a unique entity, say from breast cancer, or right, what is the basis of that? Well, it has different drivers, it behaves slightly differently. Yeah, okay, fair enough. So we need more studies for malignant tritons, but perhaps we also need more studies to see what is common between breast cancer and malignant tritons, right? I mean, you need to think about it like that as well, right? Maybe that's the out of the box thinking that we need. I think. I mean, that's what I'll say. Obviously that's a generational endeavor, but yeah.
Okay, great. Thank you, Farid. I think with that, we'll come to a close for the session for the morning. We're going to go into an intermission. Thank you, everybody, for the fascinating discussions and talks. A big thanks again to all our three speakers. We're going to break for lunch. Session 2 will be on gynecological sarcomas and will resume at 1 p.m. And this is just a plug to say, reach out to us if you work on sarcomas, whether it's any form of research or whether, you want to communicate with us. We'd like to hear from you, and that's Wei Lin's email over there. She'll put you in touch with us. Thank you, everybody, and we'll see you back again at 1 o'clock. Have a good lunch.
Thanks.
Thank you. Okay, hello everyone. Good afternoon. Welcome back to session 2 of our symposium. I hope everyone had a good lunch and you're ready for another exciting series of short talks on gynecological sarcomas. This session will be chaired by none other than Dr. Richard Quek. Let me introduce Dr. Quek. Dr. Quek is a senior consultant medical oncologist at Parkway Cancer Center. And prior to this, he was the Deputy Head Division of Medical Oncology at the National Cancer Center Singapore, when he founded the Singapore Sarcoma Consortium in 2013 and also founded the Asian Sarcoma Consortium in 2015. He is a teacher to many of us, as he was also the program director of the oncology training program when many of us were trainees. It is our honor indeed to have him chair the next session. Thank you very much for joining us, Dr. Quek, and over to you, Dr. Quek.
Hey, thanks so much, Val, and thank you so much to yourself and to the organizing committee for inviting me to chair this session. I hope everyone had a good morning session, and in the afternoon we'll be focusing on gynecological sarcomas. And so, as Val has alluded to, there will be 5 talks, starting with surgical approach, then radiology, pathology, radiation, and then med-onc to cover all aspects of gynecological sarcomas. So, without further ado, I would like to invite the first speaker. Now, there'll be 5 talks coming along the way, and there'll be a Q&A session at the end. So if you have any questions, I urge you to put your questions into the Q&A box so that we don't forget about it. And then during the Q&A box, I will then reveal the questions one at a time, and then we'll go through them and tapping on the expertise of our speakers. Now back to our first speaker. He's none other than Professor Jeffrey Lau. In fact, Professor Lau is my tutor in medical school. If I could bring him back to the mid-1990s at the time. He's the head of the Division of Gynecological Oncology and Senior Consultant in the Department of Obstetrics and Gynecology at the National Cancer Institute Singapore, NCIS. He graduated from NUS in 1987, obtained specialist qualifications in 93, and underwent subspecialty training in Australia for 2 years in 97 to 99. Prof. Lau's interests are in pre-invasive disease, radical surgery, lymphedema, and organization of a multidisciplinary care for women with gynae cancers. His research includes ovarian cancer, molecular biology, novel therapeutics, HPV vaccines, and spectroscopy for screening of cervical cancers. He's the president of the SCCPS. In 2006, he initiated collaborative network between the WHO, IARC, and Singapore for the screening and prevention of cervical cancers in rural South India. And so I'd like to welcome Prof. Lau to give us a talk. His talk will be entitled Surgical Consideration for Gynecological Sarcomas. What if a fibroid is not just a fibroid? And that's a very common question that we face in clinical care. So over to you, Prof. Lau.
Okay, thank you very much, Richard and Valerie. So I will go ahead to share my screen now. I hope you all will be able to see the slides. I'll go on the full screen mode. Okay. Okay, so thank you very much. And thanks to the organizing committee for inviting me to make this presentation, and a very good day and greetings to all our colleagues and friends in Singapore and around the world. So this afternoon, spend a little bit of time talking about the surgical considerations, and I can see that the committee has put together this title, What if a fibroid is not just a fibroid? So I'm sure this statement resonates with all of us who deal with sarcomas and also in gynecological surgery. I do not have any conflicts of interest. And so by way of introduction, for the clinician, gynae sarcomas are basically malignancies that arise from the uterine myometrium or the stroma of the endometrium. They are rare and comprise less than 10% of all uterine cancers, but unfortunately, they are very aggressive, usually in their clinical course, and have a much poorer prognosis than their very much more common malignant counterpart, which is the endometrioid carcinoma, which we see almost every few days. There'll be a new case. The classification systems are important because it gives us some idea as to where these malignancies fall under in our clinical practice. And the two common well-known classification systems are the one from College of American Pathologists and the other one from WHO. The WHO classification basically divides all the uterine tumors, both benign and malignant, into epithelial, mesenchymal, mixed epithelial and mesenchymal, and also miscellaneous. So from one end of the very benign spectrum to the other end of the high-grade, very malignant spectrum, and everything in between is encompassed by the WHO classification, which then makes it very difficult to remember. But we are focusing on today's topic on uterine sarcomas, then really we're talking about those that come under mesenchymal tumors and the mixed epithelial and mesenchymal tumors. For those of us who are oncologists, the CAP classification is probably a bit more useful. It divides these uterine sarcomas into the leiomyosarcomas, the endometrial stromal sarcomas, both the low grade and the high grade, and each with their different specific elements and differentiation. And then also the adenosarcoma, which is a mixed epithelial mesenchymal tumor, and with also some of its specific variants, and in particular, the one that we normally look for, which is less uncommon, will be the adenosarcomas with sarcomatous overgrowth. So in how common are these cancers? So in fact, they are rare, as we mentioned, when you compare them with their benign counterpart, the leiomyoma, which is very, very common. Maybe around 30 to 40% of women will have some kind of fibroid, small or maybe not so big, or sometimes very large, in the uterus or the genital tract. The age-adjusted incidence of uterine sarcomas has been reported as about 2.8 per 100,000 person years among females ages 30 to 79 years. And this incidence creeps up as the age goes on. The surgery for fibroids are probably the most common gynecological surgery. And it could be a myomectomy, a subtotal or total hysterectomy. And of these operations, the prevalence of finding a leiomyosarcoma at surgery, when the patient is presumed to have a fibroid, ranges from less than 1 to 13 per 10,000 surgeries. And this is data from 160 studies pulled up by the Agency for Healthcare Research and Quality, published in 2019. What about risk factors? Are there any ways in which we can predict? So tamoxifen has been described as a risk factor, approximately 17 per 100,000 person years. So not a very huge increase in risk. Pelvic radiation also has been classically described, and this may increase the risk as described. What about hereditary conditions? The data on these are, of course, very limited. A condition known as hereditary leiomyomatosis and renal cell carcinoma syndrome, which is a rare autosomal dominant syndrome caused by fumarate hydratase mutations, have been described to have an increased risk for premenopausal uterine sarcomas observed in some populations. And then also a condition known as hereditary childhood retinoblastoma has been described as a risk factor for uterine sarcoma. So the question that we as clinicians quite often have to ask ourselves, can the gynae sarcomas be confidently diagnosed preoperatively? So if you look at the preceding data, you can see that in terms of epidemiology, they are very rare. In terms of risk factors, there are no very strong or common risk factors like what we see in the endometrial carcinoma. As you will hear in the next two lectures from my excellent colleagues, preoperative imaging has many pitfalls, and or even coming to a histopathological diagnosis post-operatively is challenging sometimes, and pre-operatively can be even more challenging. So with this, it is therefore not surprising that we quite often encounter typical scenarios where a woman may present with a hard mass in the lower abdomen, and the clinician, being a bit suspicious, will send her for an MRI, which then shows something very irregular arising from the uterus, and reported as suspicious or cannot rule out the leiomyosarcoma of the uterus. Then, of course, the patient will get referred to a gynae oncologist or surgical oncologist, who will then send the patient for a PET-CT scan. And in this case, the PET-CT showed a low FDG uptake of this tumor in the pelvis. And then, of course, the patient will be taken to theater. And then at theater, we see this smooth, mobile mass with a normal-looking typical fibroid, and this irregular surface mass here, which if you do enough myomectomy and hysterectomies, you realize that some of the fibroids can actually look quite bizarre like this as well. So this turned out to be a benign leiomyoma, very fortunately for this young lady who underwent a myomectomy. So everything ended well for her. But the other Probably maybe also equally common scenario would be a patient who undergoes a hysterectomy for heavy menstrual bleeding secondary to multiple fibroids. And when she comes back for the histology report, comes back showing that one of the fibroids unfortunately shows evidence of high-grade sarcoma, a classic leiomyosarcoma. So we're back to this clinical question. Can they be diagnosed pre-operatively? Unfortunately, I think most of us would sadly say that the answer is no. So we are faced with the issue of very often a post-operative diagnosis of uterine sarcoma after histopath examination in a patient undergoing myomectomy or hysterectomy, sometimes a subtotal hysterectomy for presumed fibroids. So we have to ask ourselves at that point in time, what are the key surgical considerations when the patient asks us, doctor, what's going to be the next step for me? So I basically distilled it down to three main questions. Firstly, is completion hysterectomy or a cervicectomy required? So this is in a scenario when a subtotal hysterectomy has been done, cervix is preserved. Second question, can the ovaries be conserved? Third question is systematic node dissection and required. And here I'm talking about non-suspicious nodes, both radiologically as well as intraoperatively, normal looking lymph nodes. And then finally, for the sake of completion, for the sake of completeness, for this talk, I'll talk a little bit about whether there's a role for surgery in recurrent uterine sarcomas. So we quite often will ask ourselves whether systematic node dissection is required, because in endometrial cancer, this is has always been a very big issue, because the FIGO staging always includes metastasis to retroperitoneal lymph nodes in the pelvis and to the para-aortic region. So in academic practice, normally we would like to say, you know, have we staged the patient accurately? But of course, lymphadenectomy per se is not without its intraoperative as well as long-term post-operative sequelae to the patient. So in order for us to be able to answer those 3 or 4 questions, the essential prerequisites for us in our tumor groups would be to have the opinion and views of our expert gynae pathologists, as well as our expert radiologists when we send the patient for a post-operative, either a CT or a PET-CT scan. So I'm sure they'll give us some clarification, hopefully in the next 2 lectures. So we need to have these colleagues who are very, very important to us in decision making when we discuss with the patient. So for the purpose of this talk, I will divide the approach to the 3 questions based on leiomyosarcoma, the endometrial stromal sarcomas, both the low as well as high grade, and then the adenosarcomas. So at the end of this, we hopefully come up with a table, something like this, with the 3 diseases and then the 4 questions on top, so that at a glance, hopefully we can have a guide in helping us to make some kind of recommendation in this decision during our tumor board meetings and in the clinic when we encounter the patient with this sort of questions. So jumping into leiomyosarcoma, the issue of completion surgery. So for sarcomas of the uterus, the only treatment of any proven curative value basically is surgical excision, a total hysterectomy. There are several case series that support this, and it has been shown that completion resection significantly associates with increased disease-free survival. If there's extra uterine disease at the time of initial operation, and if this extra uterine disease is resectable, for example, if there is a metastasis in the omentum and the extrauterine metastasis deemed resectable, then an R0 cytoreduction has been shown to significantly improve the overall survival of patients with leiomyosarcoma. So the indications for reoperating on such patients would be two. Number one, if she's had only a myomectomy or subtotal hysterectomy, then we'll go back in to do a completion hysterectomy or a cervicectomy. The tubes and ovaries would be resected if she is peri or postmenopausal. Now, if an open morcellation has been performed in a patient who had undergone a laparoscopic myomectomy, then you advocate a re-exploration and a careful peritoneal survey. It's been published that a re-exploration of such patients within 50 days of the initial morcellation, 3 out of 8 patients were upstaged to stage 3 or 4. So I think we cannot avoid just one slide on open morcellation because there had been quite a lot of media attention from a landmark case of morcellated unsuspected uterine leiomyosarcoma, which prompted the FDA to review the role of power morcellation in 2014, and then subsequently issuing a number of position statements from various prominent societies on the role and methods of tissue extraction for uterine fibroids. So I think we have to also take on board that for the gynecologist and the laparoscopic surgeon, having an accurate pre and intraoperative assessment of whether the fibroid is indeed a fibroid is indeed very, very challenging. It sometimes can look very bizarre, but unfortunately, we know that the outcomes from open morcellation in leiomyosarcoma are associated with higher overall recurrence rates, higher specific intra-abdominal recurrence rates, and also higher death rates. So one way would be to mitigate the risk of intra-abdominal dissemination by using closed morcellation with containment bags. Next question is whether the ovaries can be conserved, because some of these patients may be premenopausal, and the data shows that in premenopausal women, the ovaries can be conserved. If they are peri or menopausal, then BSO is advocated. In quite a large series in the National Cancer Database of women with leiomyosarcoma under 51 years of age, there was no difference in overall survival, whether the ovaries were removed or resected. So if she's premenopausal, then and the ovaries look normal, it can be safely conserved for ovarian function. What about systematic node dissection? Okay, so the basic common guideline is that routine lymphadenectomy should not be performed in women with leiomyosarcoma that is confined to the uterus, and if the lymph nodes are normal appearing, both radiologically as well as intraoperatively. The incidence of node positivity in early stages is quite low, less than 5%, and we only do a node dissection or debulking if they are palpably enlarged intraoperatively or on radiology. And then in the setting of relapse disease, when the progression-free interval has been quite long, 12 to 18 months, and if the MET is isolated and resectable, surgery should be performed. The data is of course limited to small series because condition is rare, but especially in cases of pulmonary METs, you can get a median overall survival of very excellent 70 months. So there's a good role for secondary debulking in such settings. Next, we'll go to endometrial stromal sarcomas and undifferentiated uterine sarcomas. the question of whether completion surgery should be done. Again, if the disease is confined to the uterus, we will recommend a total hysterectomy. In patients who are young and strongly desire fertility, and if the lesion is completely resected, for example, in a myomectomy, then we can make a case to preserve the uterus if it is a low-grade endometrial stromal sarcoma. What if there's extrauterine disease? You would say that debulking to R0, if it's deemed resectable, this should probably be strongly considered. In a retrospective study of low-grade and high-grade endometrial stromal sarcomas of about 105 patients, in the high-grade patients, an optimal cytoreduction to less than 2 centimeters of residual disease, there was significantly longer median overall survival, 52 versus 2 months. But in the low-grade patients, the impact of surgery was unclear. 82% of patients were still alive at 78 months, regardless of surgery. How about the ovaries? Okay, so the studies had actually been mainly focused on ovarian conservation or resection in the low-grade endometrial stromal sarcomas. The incidence of adnexal mets is actually not low, about 13% in this paper. And in a systematic review of 17 studies, 1/4 of the patients that were managed with ovarian preservation were found to have higher recurrence rates, but nevertheless, the overall survival was not compromised because of the high success rates of salvage treatment. In another study published in 2013, higher recurrence rates were noted with ovarian preservation. And also in another study here, patients who have undergone BSO, the PFS of 38 months versus 11 months in those with ovarian conservation. So it would appear that for endometrial stromal sarcomas, BSO is preferred regardless of the menopausal status, except in those who are premenopausal, stage 1, and desire to preserve fertility, where disease is very localized and completely resected. We can say that ovarian preservation is an option to be discussed with the patient. What about systematic node dissection? In the low-grade endometrial stromal sarcomas, in early stage, only 5% risk of nodal metastasis, so not a high rate of nodal mets. And authors have reported that node dissection does not appear to influence the survival of low-grade endometrial stromal sarcoma patients. So overall, again, node dissection only if enlarged or suspicious. And then next, in the relapse setting, in the setting of a long disease-free interval, 12 to 18 months, if the recurrence is solitary, resectable, especially when they are located in the lung, the reports have suggested long-term survival following resection of the lung metastasis. This has been reported in quite a number of studies. And then finally, we go to adenosarcomas, the issue of completion surgery. Similarly, a total hysterectomy is recommended. In the event that the lesion is small, maybe appearing like a polyp or a pedunculated fibroid, or a small submucous lesion that can be completely resected, this has been reported as a treatment option that can be considered. In this series that has been reported of 7 cases treated conservatively, 2 of them developed recurrent disease. 1 was successfully treated with a further resection, and 1 patient was lost to follow-up. So this can be can be considered. Of course, the patient needs to be closely followed up. In terms of the ovaries, if the patient is premenopausal, you can conserve the ovaries as there's no difference in the overall survival or cancer-specific survival based on oophorectomy status for adenosarcomas. Systematic node dissection, no, because the risk of nodal involvement is very low, about 3% only. So only if the nodes are enlarged or suspicious. And then in recurrent settings, similarly, if the recurrent disease is resectable, especially if there's a long disease-free interval, then they would benefit from a secondary cytoreduction. So having gone through the sort of the 4 questions for the 3 categories of conditions, we can fill in our table this way and have an overview of what we've discussed. In leiomyosarcoma sarcoma, we'll advise a total hysterectomy, extrauterine debulking to R0 if this is feasible. If there's a prior myomectomy or subtotal, then they should have completion resection. And if there was open morcellation, then this would warrant a re-exploration and careful peritoneal survey. The ovaries can be conserved in premenopausal women. They should be resected if peri or postmenopausal. Node dissection, not necessary. Relapse setting, isolated, resectable, long disease-free interval to go ahead and do a secondary cytoreduction. And this can have a benefit of quite long overall survival. For the endometrial stromal sarcomas, similarly, a total hysterectomy. If there was a prior myomectomy, then the uterus can be considered for preservation in low grade. If the patient strongly desires fertility, and then we will proceed to a completion surgery after she has completed family. Extrauterine debulking to R0 if feasible. BSO is preferred for endometrial stromal sarcoma. Okay, so here, this one is slightly different from the other 2. So it's worthwhile to remember that across the board, regardless of the menopausal status, BSO is preferred in endometrial stromal sarcoma, but can be discussed as an option for early stage premenopausal patient if the disease is well circumscribed and completely resected. No need for lymphadenectomy, and same thing, secondary cytoreductive surgery, especially for lung metastasis if isolated and resectable. In adenosarcoma, which are generally indolent low-grade tumors, similarly, total hysterectomy and option for local resection in the younger patients. If premenopausal, the ovaries can be conserved, no need for lymphadenectomy, and same thing in the relapse setting for isolated and resectable metastasis. So to have an executive kind of summary of everything that I've said, overall surgical considerations for uterine sarcoma, total hysterectomy is the main procedure that makes any survival different significantly. If there's prior morcellation, we should re-explore the patient. If there's extrauterine disease, debulk to R0 if feasible. In the young patient, early stage, low grade, there's an option for fertility preservation. In a premenopausal patient, the ovaries can be conserved except for the low-grade endometrial stromal sarcomas. Routine node dissection, no, because the rate of METs are very low. In recurrent disease, surgery for oligometastasis after long PFI, especially beneficial for lung metastasis. I think this is my last slide. So thank you very much for your attention.
Okay, thank you, Prof. Loh. That's a very, very comprehensive talk, and I'm sure all of us have got many questions, including myself. We'll keep the questions for later. And if I could urge all the audience and the participants to write your questions in the Q&A box, and we'll try to get to all of them at the end of the session. Now, following the first talk by Prof. Loh on the surgical aspects, we'd like to turn our attention on the radio imaging aspects of gynecological sarcomas. And we have Dr. Chan Wan Ying to give us a talk. She's currently a consultant in oncologic imaging at NCCS, National Cancer Center, Singapore. She received her medical degree from the NUS in 2012, and she was awarded fellowship of the Royal College of Radiologists and Master of Medicine in Diagnostic Radiology in 2016. Her research interests include body imaging techniques, MR imaging, and translational research. And she'll be giving us a talk on the imaging pitfalls in gynecological sarcomas. So without further ado, we'd like to invite Dr. Chan to give the talk. Thank you.
Okay, good afternoon, everybody. Thank you, Dr. Quat, for introducing me. I'd like to also thank the organizing committee for giving me this opportunity to talk about imaging pitfalls in gynecological sarcomas. And as Prof. Lau has emphasized earlier on, gynecological sarcomas are very rare tumors, and uterine sarcomas consist of less than 10% of all malignant tumors. So today I would mainly talk about uterine and ovarian sarcomas. The three most common histological variants are malignant mixed Mullerian tumors, also known as adenosarcomas, leiomyosarcomas, and endometrial stromal sarcomas. I'll also give an example of rare sarcomas, which are rarer than the rest. And sarcomas are in general the most malignant group of gynecological tumors with regards to their clinical pattern, the spread, as well as the management, as we will go through later. Currently, ultrasound, CT, MRI, and PET-CT are being used to evaluate patients with gynecological malignancy. Ultrasound is the first imaging modality of choice for first identifying whether this is a uterine or an annexal mass due to its accessibility and its relatively cheap option. But it is most often not very useful, later as we can see. Then we move on to the cross-sectional imaging, such as CT. We often get CT abdomen pelvis for evaluating pelvic masses at presentation or for non-specific presentation, such as abdominal distension, loss of weight, loss of appetite, as a sign of disseminated disease. And MR pelvis is the main modality used for detecting the extent of local disease and also helps to give a local staging. This is primarily the modality that you're going to see for the rest of the slides. And finally, there will be some images on PET-CT. This will be helpful for detecting distant metastasis and also add some metabolic information in cases of indeterminate nodal disease. So first, we'll come to ultrasound. Ultrasound is limited in assessment of gynecological sarcomas, except first to tell if it's possibly an annexal or uterine origin. The sarcomas often show similar heterogeneous masses with some mixed echogenicity and increased vascularity. And here, this is one of the ultrasound of a malignant mixed Mullerian tumor. On your left, you can see this is the bladder, and this is the uterus. And on your right is another ultrasound of another lady with leiomyosarcoma. Here you can see that there are irregular tumors over here with irregular margin, as well as increased vascularity. And these two are quite similar in characteristics, so it's not possible to differentiate them. So therefore, we need MRI. MRI is superior to ultrasound for identifying the origins of the tumor. We must first look at where is the center of the tumor. This is the typical MRI sagittal plane of a normal uterus. And the uterus is divided into the outer myometrium, which is over here as a more T2 hyperintense signal, layer, as well as the inner myometrium, dark T2 band, also known as the junctional zone, as well as the endometrium inside over here. And the junctional zone is important because it's a low signal band that's contiguous with the cervical stromal ring, and this is also used for staging. The tumor either originates from the endometrium, such as the endometrial stromal tumor, and invades into the myometrium, whereas the leiomyosarcomas originates from the myometrium and displaces the endometrium. And this is one of the example of MMT, and it contains both sarcomatous as well as carcinomatous component. They usually present as a large soft tissue mass, as you can see in this MR coronal as well as sagittal images. This is a large soft tissue mass expanding the endometrial cavity with marked myometrium invasion. Note the normal myometrium over here as well as invasion along the superior aspect, and with some areas of necrosis and hemorrhage. And you can see some difference in the component of this tumor. This is a more T2 hypointense component, and this is the more T2 hyperintense component, reflecting their heterogeneous subtype. And this is a CT of again, another lady, 48-year-old lady. This is the uterus. As you can see, there's expansion of the endometrial cavity with what we call as a front-like appearance of the tumor due to its soft tissue component. It also invades and tints the myometrium. And it shows early extensive peritoneal disease. As you can see over here, this is the large omentum caking at the superior to the uterus and below the transverse colon over here, and also anterior to the uterus. You can see some large volume ascites as well as some peritoneal deposits, as these tumors usually show early development of metastasis. And you can also use PET. PET will show you metabolic activity. And this is an example of a right ovarian MMT showing you this large mixed solid cystic tumor along the right axial region with evidence of peritoneal implants. You can see that the implants shows intense FDG avidity similar to the solid component of the tumor itself, which is helpful to look for disease as well as nodal as well as peritoneal disease. Next, we move on to the leiomyosarcomas. These are malignant smooth muscle tumors. They arises de novo from the myometrium or from the smooth muscle from the myometrial vessels. The best diagnostic clue for this kind of tumor is this heterogeneously enhancing irregular mass with areas of necrosis as well as hemorrhage. As such as this 59-year-old lady, this presentation was for increased abdominal distension. And you can see that this is the appearance of the part of the uterus. This is the normal appearance of a fibroid posteriorly along the posterior wall of the uterus. And here coming superiorly, you can see this irregular massive uterine enlargement all the way to the level of the umbilicus with areas of hypoenhancement over here, reflecting extensive necrosis as well as hemorrhage. And you can note the irregular looking wall margins of this lesion, as well as abnormal amount of ascites in the abdominal cavity. So what happens if they are not as big as the earlier case? Then it may be hard to differentiate this from a fibroid. And one of the clues is to look for the internal composition of the tumor. The lesions usually show intermediate to high T2 signal because of its necrosis and heterogeneous enhancement. And this is where the myometrium is very important. You can see the thinned out myometrium over here. It must be smooth and contiguous. However, along the right lateral aspect, you can see some effacement of the myometrium and loss of the signal over here. And this is a sign of invasion and start of extrauterine extension. We also can look at DWI ADC to look for signs of cellularity of this tumor. You can see some restricted diffusion inside this tumor, which reflects its cellularity. So these features are not typical of a fibroid, and therefore this was subsequently excised and proven to be a leiomyosarcoma. Ovarian leiomyosarcomas are extremely rare. They arise from the smooth muscle component or either of vascular origin, such as the gonadal vein, or the smooth muscle component of the ovary. And this is the MRI of a right annexal mass. You can see this predominantly cystic mass of the ovarian origin with some internal septations over here, as well as some enhancing solid component. And here you can see this is the sagittal view of the pelvis. This is the normal uterus over here with the thinned endometrial cavity. And this is therefore an annexal mass. You can see some fluid level. This is indicative of hemorrhage. And this is actually not possible to differentiate from a mucinous cis adenocarcinoma, but it was subsequently excised and proven to be a leiomyosarcoma. Then we move on to the endometrial stromal sarcomas. These are malignant mesenchymal tumor of the endometrium, and they are high-grade sarcomas. Usually, they are very aggressive and they infiltrate with local invasion directly through the myometrium and into the surrounding organs. As such, with this 70-year-old lady, this CT scan of her pelvis shows this large heterogeneous endometrial-based mass. You can see parts of the what is remaining of the myometrium over here. And these are all abnormal myometrium, which have all been invaded. And here along the fundus of the myometrium, you can see the extra uterine extension beyond the myometrium and invasion into the surrounding organs. I'll give an example of this kind of rare tumors. These are not possible to differentiate from the rest of the uterine sarcomas. Pure rhabdomyosarcomas are extremely rare, even though sometimes you can see rhabdomyosarcomatous component as a component of the MMMT. This is a pure rhabdomyosarcoma. You can see how irregular and how bizarre the enhancement is. It distends the endometrial cavity over here with evidence of extra uterine extension. And this poor enhancement over here is a reflection of its rapid growth and protrusion into the cervical canal, and therefore there's on the necrotic over here. One of the pitfalls is to first make sure that we don't diagnose leiomyosarcoma in myoma. This is not a big problem most of the time because the fibroids have a typical appearance. And this is a typical appearance of a fibroid. You can see this well-circumscribed margin, low T2 signal with a walled appearance, and homogeneous enhancement with no evidence of invasion. You can see the uterus next to it, looking quite good, and the endometrial cavity, junctional zone preserved. No signs of invasion over here. This is easy to diagnose. This is a large fibroid. However, non-degenerated fibroids have typical appearance. Fibroids with myxoid or cystic degeneration can be difficult to differentiate from sarcoma. And this is one of the MRI pelvis of a 51-year-old lady. Here you can also see a well-circumscribed intramural mass. This is the endometrial cavity, which is thin and normal. But in this mass, you can see some T2 hyperintense signal, reflecting some signs of cellular degeneration. The outer myometrium, again, very important over here, remains thin but smooth with no evidence of invasion. And I would like to compare this with the earlier case of leiomyosarcoma. You can note that the myometrium is also thin, but it's not smooth along the lateral aspect over here. So you can say that, oh, I will use a PET-CT because PET-CT will give me a metabolic activity. And sometimes it's actually not very helpful in differentiating benign from malignant tumors because benign lesions, not just fibroids, but also endometriotic cysts can also be metabolically active. The fibroids are known to show a wide range of FDG avidity. They can be heterogeneous even within the same fibroid if it is big enough. And they are known to be regulated by hormones, cellularity, vascularity. So they do show mixed FDG uptake. And as such is this PET-CT of a 43-year-old lady. You can see this mass posterior to the normal and unenlarged uterus with some fluid in the pelvis. questionable for sarcoma. And you can see this corresponding intense FTG uptake posterior to the normal uterus, which is not showing much uptake. This is the normal bowel uptake next to it. And this was subsequently excised and shown to be a fibroid. Next, we want to rule out something that's irregular and with irregular margins, because irregular margins is a sign of malignancy. And this is one of the benign conditions with signs of irregular margins. This is adenomyoma, which is a more mass-like appearance of the adenomyosis, and it's a benign condition involving the myometrium. Here you must look at the junctional zone. It is more often than not thickened because it's a thick T2 band. And how do you differentiate this from a leiomyosarcoma, since they both arise from the myometrium? Is first you look at the T2 signal. The T2 signal must be a bit low because it's a junctional zone infiltration, so it must be low. And secondly, you look at the pre-contrast T1 images. And what you're looking for is this high T1 foci with corresponding high T2 foci within this mass. And these are thought to be cystic spaces with hemorrhages, which is not common in, which is a very typical feature of adenomyoma. And sometimes you can also see endometriotic cysts with similar signal as a sign of benign condition. Another diagnostic clue is to differentiate this, is to look for signs of myometrium invasion. This is a case of a 37-year-old lady, also query fibroid with cystic degeneration versus leiomyosarcoma. And I would like to compare this with an earlier case. You can see that these two lesions are quite similar, quite heterogeneously enhancing over here. The myometrium looks all right over here, quite thin because of the large tumor over here. However, at the anterior aspect, you can see that there is some subtle kind of protrusion of the tumor over here, and this is not present in the known leiomyoma. You can see just a tiny bit of protrusion over here, and this is later proven to be a leiomyosarcoma. Some lesions can be relatively well circumscribed and they cannot be differentiated on CT, but on MRI, they do show quite well as infiltrative myometrium invasion. As such as this 32-year-old lady with a mass. You can see that this is a subtle myometrium invasion. You can see the outer myometrium, and the inner junctional zone over here preserved. And here, as you come down to the anterior aspect at the fundus, you can see that the signal is lost, and it's coming back again to a normal junctional zone. So this is a subtle myometrium invasion, revealing its malignant behavior. You can also look at the ADC and DWI map. Most people don't like to look at that. These are axial and sagittal T2 images of a 74-year-old lady. Again, a polycystic mass in the myometrium, also query leiomyosarcoma. Besides looking for the myometrium, sometimes it can be quite thin and quite difficult to look for. You can also look at the ADC map. These are DWI ADC. They are read together with anatomical correlation using T2 images. And this is a measurement of Brownian motion of water molecule, and in this context, it represents the tumor cellularity. So if the tumor is highly cellular, it's bright on DWI with corresponding dark foci on ADC. And you can see this is not just a simple cystic degeneration. These are areas of high DWI over here with corresponding dark T2 foci over here, as well as this area. This is later excised and proven to be a leiomyosarcoma. And I'd like to contrast this with another scan of another large mass again, similar appearance on T2 imaging, but on the DWI, you can see that this is bright on DWI. However, it is also bright on ADC. So this is actually not a reflection of cellularity. But the physics behind this is beyond this talk, and this was again excised and proven to be a leiomyoma. The last point, which is a bit difficult, is the temporal evolution. It's only possible when you are following up something for a long period of time. And these are the images of the 29-year-old lady who has been being followed up for fibroids, and the fibroids has been stable for 3 years. However, in the recent half a year interval, it shows a significant increase in size. Even though there's no evidence of invasion, there's no evidence of spread, this was subsequently excised and proven to be a leiomyosarcoma. So leiomyosarcomas arising from a pre-existing leiomyoma is extremely rare, but the rapid increase in size may suggest otherwise. So I'd like to end off my talk with some conclusion. First, you need a good clinical history because it allows us to choose the appropriate imaging modalities and give a clue to this, how these lesions evolve. And the imaging features of sarcomas are actually unfortunately not specific because any uterine sarcomas are highly malignant. They can appear as large heterogeneous aggressive mass in the uterus. And it's not possible to distinguish the various subgroups of the uterine sarcomas. Therefore, the diagnosis is most often not based on pathological findings. But it's important to differentiate the malignant tumors from other benign conditions. And if good knowledge of this imaging spectrum can help in surgical planning and also in management. Similarly, it's also good to have a working relationship with surgeons. And I would like to thank Prof. Tay from ONG side for his database for sarcoma cases. And finally, I would like to thank everyone for your time, and I'm happy to take any question later.
Okay, thank you so much, Wan Ning. That's an excellent talk. Clearly a lot to learn from, clearly a lot to benefit from your discussions with the radiologists. So next up is Satya. Dr. Satya is a consultant pathologist and a good friend of mine. He's currently a senior consultant with the Department of Anatomical Pathology at the Singapore General Hospital. By way of introduction, he's a core faculty in a pathology residency program. His research interests are in bone and soft tissue sarcomas, GIST, and hair and neck pathology. Today, he'll be delivering to us a talk entitled The Challenges in the Pathological Diagnosis of Gynecological Sarcomas. So with that, I hand over to Satya. All yours, Satya.
Hey, thanks, organizing committee, as well as Richard, for your kind introduction and giving an opportunity. Time constraint is a big thing here. In 20 minutes time to summarize the gynecological sarcoma, which is unlikely. So I'll try my level best to share most important sarcomas in the female genital tract. Sorry, where is my screen? I'm finding difficulty in sharing. Sorry, yeah, I think some issue with the opening the file. Just give me a minute. I'm opening. Can you all see my screen?
Not yet. Yeah, now we can.
Okay. Okay. Without delay, there is nothing to declare. I'm starting with this case of a 48-year-old Chinese female with one miscarriage is represented with the worsening vaginal bleeding and symptomatic anemia requiring blood transfusion. Pelvic ultrasound, a bulky uterus with several dilated blood vessels.
Sorry, Dr. Satya, sorry to interject. I think we're looking at your PowerPoint program rather than the actual presentation. Maybe it's a different screen.
But it says your screen sharing.
So what we're seeing is the PowerPoint on the title slide.
Or could you put it to what do you call it? Slideshow mode.
How about now?
Yes.
Yep.
Yep. Looks good.
Okay. Sorry, this technical glitch is always happens during the important moment. Okay, I'm starting with this case of 48-year-old female with one miscarriage history and presenting with worsening vaginal bleeding and symptomatic anemia, requiring blood transfusion. And pelvic ultrasound showed a bulky uterus with several dilated blood vessels. And Doppler also highlighting what's seen in the ultrasound, vascular structures with all those terminologies what an interventional radiologist use. So MRI was done and enlarged uterus, again with a tangle of dilated vessels, no definitive mass seen, rather more dilated vascular spaces. So patient underwent hysterectomy and the specimen has been sent to us. So why it's not moving? Next thing. Again, sorry, I'm not sure what's happening, why it's. I reshare again. You all able to see my screen?
Yes, we can.
Is it showing my next slide?
It's an ultrasound on the left and some
Yes.
MRI.
Okay. So
Yep.
this is a picture shared by my other specialty colleague, which showed the changes radiologists can interpret easily what is seen here. So it's a Doppler interrogation showing both arterial and venous waveforms, and MRI showed about changes with again enlarged uterus with a tangle of dilated blood vessels. So why every slide is finding difficult. It's not allowing me to share my PowerPoint slideshow.
Or you could try the down button key and see whether it works or not.
Yeah, I'm trying all the means. Okay. Yep. Can you able to see my gross picture? Next slide.
We don't see the slideshow mode at the moment.
Oops. Now?
Yes, we see a surgical specimen.
Okay. Hopefully it goes well. So this is the cut section of THBSO received. You can appreciate at the fundus, all these dilated spaces, definitely there is no mass forming and filled with altered blood. And histologically, every slide. Okay, this is the medium power magnification of the sections taken from that dilated vasculature area, which shows some proliferation of the round cell morphology not really very much of high-grade features, but definitely not fitting into a straightforward diagnosis of leiomyo, that is a benign smooth muscle tumor, malignant, or even a stromal tumor. So this further higher magnification show these changes, and bundle of epithelial tumor cells within the myometrium in a perivascular arrangement. They had a clear to pale granular cytoplasm, mild pleomorphism, and very inconspicuous nucleoli, as well as not much increased mitosis or necrosis. So it's an epithelioid spindle cell tumor. What is it? Is it some vasoformative? Is it a smooth muscle origin? Or is this an epithelial tumor? Or is this a metastatic deposit? So with this, I'm moving into the my presentation, malignant and tumors. So the female genital tract is quite a larger area where quite a number of tumors are even though the percentage of mesenchymal tumors are very less compared to the epithelial tumors and germ cell tumors. So when I divide according to the specific sites, uterine corpus bears the largest volume of the mesenchymal tumors, of which these are the commonest tumor which we come across: leiomyoma and leiomyosarcoma, endometrial stromal tumors,